Terrific. Thank you, Karen, and thank you to my fellow commissioners. This is the October meeting of the Healthy California for All Commission, a early Pacific Coast start time relative to what have been mainly afternoon meetings. So grateful to everyone for being flexible and moving things around. I know we're coming off of a significant number of meetings with great content, engagement, and just grateful for how far we've gotten together as a group. And we still have more to go. Today will be a very important meeting. Really looking forward to our three presenters and the discussions that we will have. But before we get into that, Karen, can I turn it back to you to go over our protocols and take roll?
Yes, thank you, Secretary Galley. Good morning. So turning to our next slide, our meeting protocols for the Zoom meeting today are as follows. The meeting is being recorded. Commissioners, you have the ability to mute and unmute and to use your cameras to be on video. Please do keep yourselves muted when you're not speaking to reduce background noise. We'll use the raised hand feature, unless of course Secretary Galley calls on you. For members of the public, welcome. You can listen and view the meeting today, and there will be a public comment period in the latter part of the meeting, at which point we'll open up the chat feature for written public comment. You can also always provide written comment via the email address of healthycaforall@chhs.ca.gov. And during public comment, we will also invite verbal comment from members of the public. All public comment that we receive during this meeting will be part of the public record and posted to the Commission webpage following this meeting. Okay, in terms of roll call, as I state your name, Commissioner, if you could just unmute yourselves and say hello, that would be lovely. And we'll start with Secretary Galley.
Good morning. Great to be here.
Carmen Comsty.
Good morning and happy Indigenous Peoples Day, everyone. I'm calling from Ohlone lands, also known as Oakland.
Jenny Chin Hansen.
Good morning, Jenny here.
Bill Shao.
Good morning, I'm here.
Bob Ross.
Good morning. I'm here calling from the Fang-Chonga tribal lands and hoping our chair, Dr. Galley, that we don't suffer an irreconcilable savage rift among the commission members should the dastardly Giants prevail over the Dodgers this week.
Richard Scheffler. Commissioner Scheffler, are you unmuted? Oh, sorry, he's just popping back in. I'll come back to him. Sandra Hernandez.
Good morning. Go Giants.
Andy Schneider.
Morning,
By the
everyone.
way, I've just unmuted. I'm sorry, I'm here now.
Good morning, Commissioner Scheffler.
Good morning, everybody. I'm a Giants fan.
Andy Schneider.
Good morning, everyone. I'm not choosing sides.
Sarah Phlox.
Morning, present.
Kara Desert.
Good morning, everyone. Calling in from Kumaya land today and wishing everyone a happy National Coming Out Day.
Antonia Hernandez.
Here, go Dodgers.
Anthony Wright.
Good morning from Yolo County, Patwin land.
Rupa Maria.
Good morning from Miwok territory. I'm coming home from vacation with my family, and I'm happy to be here with you today. Happy Indigenous Peoples Day. Every day is Indigenous Peoples Day.
Richard Pan.
Present.
Jim Wood.
Here. Good morning.
Michelle Boss.
Good morning.
Peter Lee.
Well, first, coming out as a former Dodger fan, thinking orange and black were colors of the devil, now coming out as a strong Giant supporter and celebrating Coming Out Day as a proud gay man. Thank you.
Don Molds.
Good morning.
All right, I think that covers it. Secretary Galley, I'll pass it back to you.
Perfect. Thank you, Karen, and appreciate the acknowledgement of today being Indigenous Peoples Day and all of the great banter between the commission. Bob, I think we will escape any casualties or rifts from the Dodgers Giants. And for Andy, you should take solace in knowing that the Nationals have provided the strongest part of the Dodgers lineup at a late season trade. So you should hate the Dodgers and love the Giants per some of those trades made at the end. Nonetheless, I wanted to jump in with some opening remarks before we get into today's top mission cadence and what lies ahead. So this is our October meeting. I think if you could advance to the next slide, Karen. So we have 3 remaining meetings left, a November, a December, and a January meeting. We intend to really spend the next couple of weeks debating, talking through, even surveying some of you on what remaining topics should be focused on in those meetings. And who we might invite to speak and present to us, whether it's another commissioner or an outside speaker like we have 2 today, and ensure that we're trying to touch on all of the major topics that could help inform our final report. If we need to revisit anything that we've already reviewed, we can figure out how to do that either within the meetings or using our survey style that has been, I think, very helpful as well. I think the next slide has where we are on the meetings November 18th, December 9th, and January 12th. We intend to really start getting the shell and the bones of the final report, even though we don't have all of the components discussed yet as a commission, at least put together so that we can start to circulate that sometime in advance of the January 12th meeting so we can get that feedback. And then, of course, we can determine how we use that final meeting to really focus on the report and make sure that we get enough of everyone's feedback to be able to come down the home stretch and get it completed. We also, in the next couple of weeks, I'm grateful for about a 4-week, actually longer 5-week break between today's meeting and the next meeting so that we can do some time preparing and putting together, I think, the whirlwind of information and feedback that we've gotten over the last few weeks, but also be prepared that in about 2 weeks, we'll be sending a revised commissioner and expanded commissioner survey around the goals, values, and propositions. It will continue to have the questions and feedback that people provided to the last survey, and then add some additional questions, clarifications that we took from the last survey response from all of you, and then of course add some more questions and things for our commission to opine on. So again, 2 big things, survey and then connection with many of you, and please reach out to me directly if there are topics that you feel are germane that we haven't yet either touched on or that we need to take a deeper dive on. I know that we will not have enough time to do everything every commissioner feels is valuable. I will likely share your view that it's valuable and then try to figure out how, if and how we can fit it into our entire commission proceedings. Before we move on, I just want to make sure that I didn't miss anything else. I don't think I did. So yeah, just expect some engagement, even though we have a 5-week break with each of you over the next few weeks. So with that, let's jump into our next slide. So today, I think it's one of the most essential topics that we're going to talk about in payments. We've been sort of building up to this moment. A lot of discussion about how payments can be used has already occurred, but today will be just entirely focused on this topic. I think the simplest way I think about it is a unified financed health system creates a single pot of funding that is distributed as payments to some set of entities in some structure under some approach to drive towards a certain set of services and approaches that ideally maximally benefit its beneficiaries. So if we look at that middle step of payments, I think it's really a conversation about at least three things. One, who do we pay? Second, how much do we pay? And third, what are we paying for? And so today's conversation really brings us three presentations that are going to allow us to dig into some components of that. But before we jump into those, I want to just make a few comments. I know that there's no doubt that our current system is a patchwork, that the funding streams come in a number of different ways and they go out in a number of different ways. We have different payment and reimbursement arrangements to support different populations based on whether it's public or privately financed, and that we really try to use those payments to provide some sense of stability to both the safety net system and the broader system, healthcare delivery system. That all said, I think we all appreciate and know, and part of our drive on this commission is to think through the fragmentation that exists. And the fact that that fragmentation drives a number of, whether they're intended or unintended, consequences that we all believe do not drive to the improvement of health of our communities and our people, Californians at large. That this has come in the form of historic inequities, whether those payments and the way that we fund the services end up driving who works where, what they're paid, how we value the different components of cultural nuance in our different communities across the state, certainly have driven, been part of the story that drives the inequities that we see in health, the access issues, the cultural concordance, the language barriers, etc. We also know that the systems are quite different on the public side and the private side, not just in the rates, but how they are paid and who actually delivers the services to these two different populations who get their care under either that Medicare and Medicaid on the one hand, VA as well, closed system, and then our larger commercial or private system. Under today's system, in addition to that fragmentation, we also have an array of different funding mechanisms for different types of services. We've talked about how public health is really carved out in a way, and I think the pandemic has forced us to pay attention to how public health is actually funded. Categorical funding from both the federal and the state resources, some local resources, obviously philanthropy. They look at our foundations who've been really done a lot of heavy lifting on keeping public health going, but it's funded in an entirely different way than the healthcare delivery system. That even within that, we see differences on how physical health and behavioral health, as an example, are funded, and not just how the funding is paid today, but really how the history of how those two entities or two different types of services are funded have driven how we value behavioral health versus physical health, how we elevate and enhance and innovate the workforce that's available. And there's no surprise that not just in California, but across the nation, we see this chasm between behavioral health and physical health that we are now working so hard here in California to close. Also, from a provider perspective, the patchwork of how we fund these services drive a whole set of different behaviors. And with the consulting team last week, given some of the really excellent pre-meeting reading that was sent around, we spent time talking about how there's just a great deal of uncertainty for providers as well. We expect providers and systems to behave in certain ways, to prioritize certain things, to focus on preventative upstream services, when in fact still today, many of our payment systems pay for things more downstream, prioritize that both in how much we pay and how easily we make the systems to get paid in those aspects. And then also just the fact that providers often are not sure how they're going to fare year over year in various systems. And that uncertainty creates and drives a set of behaviors that I think some of the readings from last week, in particular, some of the ones that Josh and Dana shared with us, really drive that there are ways to use our payments to create some certainty among providers so that they can focus on whole health rather than just the widgets of healthcare that sometimes get put together, not in the most elegant, not most efficient, and not most effective way to drive towards total health improvement and better health for our state. So obviously we've talked a whole bunch about the values that we want to see driven in a unified financing system. And today is a conversation largely about how we use the dollars that come into the pot to pay for things that we think are really going to drive those values to their utmost impact on our people and on our future. So before turning it over to our first speaker, today we have three speakers, Don Molds, Dana Safran, and Josh Sharfstein, who I'll let introduce themselves a little bit because of what the relevant parts of their roles to our conversation today. I just want to leave us with the question: under a system of unified financing, how could payment arrangements be reimagined, rebalanced to drive towards those aspects and attributes that we've been talking about: high quality, equitable, accessible, and affordable healthcare for all? So today is going to get technical. I think you're going to see a lot of data, pretty dense slides. We really hope that those who've had a chance to take a look at some of those pre-meeting materials will engage. Those are fair game as well. Raise questions that you read there. Raise questions that come up in the conversation today. I hope we'll have a lot of back and forth between the commissioners, like I usually do at the end of the three presentations. And I think at least two of our three presenters are going to be with us throughout the entirety of the meeting. Josh and Don, still waiting to figure out myself whether Dana is going to be able to stick around for the entirety of the meeting. If she can, we'll just engage all together after all three presentations. If she's unable to, I'll flag that for all of you. So if there are specific questions for Dana, we can get those in early, and then Don and Josh will engage with you afterwards as well. So I'm really looking forward to today's meeting. I know you put in a little bit more work than normal to prepare for today, but I think it will make it a much richer and better discussion. So with that, if we can go back to the slides, Don, I'm going to turn it over to you. Don Molds is CalPERS Chief Health Director. He's been there a few years, just came sort of at the beginning of this administration, but has come with a great deal of influence and exposure over health, not just in the nation, but globally, thinking about comparative systems, and really looking forward to your presentation, really focused on variation in cost and quality, how we look at how we pay for things today. And I think, at least in your final slides, I think some very punctuating questions for the commission to think about. I'm hopeful that those questions, Don, will be able to engage on towards the question, sort of the Q&A part of the conversation. So we'll want to keep Karen that slide potentially to pop back up towards the end of our time together. So with that, Don, I'll turn it over to you. Thank you.
Great. Thanks, Secretary. Can everyone hear me okay?
Yes.
Great. Perfect. All right. So you have obviously two great speakers that follow me this morning. So most of what I'll be doing is stage setting. I'm going to take a couple of minutes to lay out the key cost-related challenges we face nationally and here in California. I'll try to dispel a few misnomers about what drives costs. And then I'm going to dig in on what drives costs at CalPERS. I'm also going to talk or touch on anyway, payment reform, although I'm leaving the lion's share of that to Josh and to Dana. I'll say a little bit about the payment reforms that have been prominent so far. I'll be talking about why payment reform can be so challenging. And then, as Mark noted, since I was trained as a philosopher, I would feel compelled to leave with some questions. So I've queued up a couple of questions that'll hopefully help with the discussion moving forward. Next slide, please. This slide charts healthcare spending growth over the last 50 years. In 1970, we spent 6.9% of our gross domestic product in the US on healthcare. By 2019, the amount spent on healthcare increased to 17.7% of GDP. You can see that in the last 50 years, we've had a couple of periods where health spending was relatively flat, but the overall trajectory is pretty consistent. The US spends a higher percentage of GDP on healthcare than any other nation in the world. And since we also have the highest GDP in the world, we spend more in real dollars. For perspective, in the US, we spend less than 5% of our GDP on education. Next slide, please. Slide provides a little more detail about the growth of healthcare spending. As you can see, healthcare spending has outpaced both inflation and economic growth over the last 50 years. Unless that trend changes, we're going to continue to see it eat up a higher percentage of our GDP over time. This strains government budgets at both the state and federal level, and it makes it more challenging for employers to raise wages. Slide 4, please. This is a chart from the Commonwealth Fund, which shows us how our spending stacks up against that of other wealthy nations. As you can see, we spend almost 50% more on healthcare than the Swiss, who spend the second most on healthcare. I mentioned that these numbers look worse when you take into account the fact that the US has the highest GDP in the world. When you compare real dollar spending of the countries on the bottom of the list, those are the ones spending the least or the most efficient. Australia spends right about half of what the US spends on healthcare, and the other 3 countries, the Netherlands, the UK, and New Zealand spend less than half of what we spend. Next slide, please. This is the what do we get for our investment slide. Here we're looking at disease burden, which accounts for both premature death and years living with disability. It's worse in the US than any of the other comparison countries, and not by just a little bit. Notoriously, the US is worse in many public health categories. We have the shortest life expectancy, the highest rates of infant mortality, and the highest rates of chronic disease of any of the wealthy nations. Next slide, please. I mentioned this chart in our last meeting, but I wanted to bring it up here because I think it's central to how we think about both health and spending and about payment reform. This is a slightly outdated accounting of both global health spending and global spending on social services. If you were to fast forward to a more recent snapshot, what you'd see is the US spending an even higher percent of GDP on healthcare. In fairness, the slide also doesn't capture recent increases in social spending that are part of the US pandemic response. Like other comparison slides, these are all wealthy countries. Social spending here includes food and housing supports, case management, and select community investments. Notice that for all or almost all of the countries represented in this chart, social spending significantly outstrips health spending. The majority of countries spent about twice as much on social supports as they do on healthcare, and no country other than the US spends more on healthcare than it does on social supports. By contrast, the US spends almost twice as much on healthcare as it does on social care. There are a lot of people who believe that our anomalistic ratio of health to social spending is driving our poor showing when it comes to health outcomes. It is almost certainly contributing to inequities that plague the US healthcare system, and I would argue that it's likely making our health spending problem worse. Bob drew some of these links in his terrific presentation on health equity a few weeks ago. when he identified zip code as a major driver of health outcomes. I certainly saw it on our work on homelessness when I was in the federal government. A high percentage of chronically homeless individuals suffer from serious but treatable mental illness. Research from over a decade ago shows that when they are housed, particularly when they are housed with adequate supports, they tend to stay on those medications and avoid very costly hospitalizations. The fact that we haven't significantly increased our stock of subsidized housing in decades now means that we continue to chase our tail on this and many other housing related problems. In the case of the chronically homeless, we spend a fortune on emergency room care and preventable hospitalizations, and we cause needless harm and suffering along the way. I think this issue is also critical for any discussions of payment reform. If we don't broaden our aperture beyond questions about what we should and shouldn't be paying for within healthcare, we're not going to make progress, the progress we're trying to make. Next slide, please. This is a snapshot of the CalPERS health spend. CalPERS buys healthcare for employees and dependents of employees who work for California and for employees of select local governments and local governmental agencies. We also provide healthcare for qualified retirees in those entities. We're the second largest purchaser in the country of group healthcare, the largest purchaser of group healthcare in California. We expect our 2021 spend to come in right around $10 billion. That money goes to provide healthcare for about 1.5 million people. Next slide, please. This chart gives you a sense of where our health care dollar goes. The two categories representing drug spending are slightly exaggerated here because they don't include sizable rebates we receive from drug manufacturers, but the amount we spend on drugs is still staggeringly high. Notice that over a quarter of our spend goes to inpatient services. Our preventative care spend is somewhat underreported here because it's captured in some of the other categories, but it's still worth comparing to what we spend on emergency room services. That's the larger, slightly larger piece of the pie. Next slide, please. Our spend at CalPERS tracks closely to the distribution of spending we see nationally. That's what's represented in the second of the two charts in this slide. The only noticeable difference you see between our spending distribution and what is shown here is that inpatient services make up a higher percentage of our spend. I'm not showing you this slide to talk about spending distribution though. I'm sharing it to talk about what is and isn't driving healthcare costs. Take a look at the first of the two charts. The solid lines track average price, the dotted lines track utilization. What this shows pretty clearly is that prices are driving the growth in our health spending, not utilization. In the 4 years that are represented here, we see very modest growth in the use of medical goods and services, coupled with a very dramatic decrease in the use of inpatient services. Prices climb significantly in each category, though, and really are the fuel behind spending growth. My takeaway from this slide is that our efforts to right-size healthcare spending needs to be focused on the prices of healthcare-related goods and services. It's also one of the reasons that I'm suspicious of efforts to curb healthcare spending that focus on making it harder to use services. Not only is utilization not driving healthcare spending growth, but most efforts to curb utilization rely on cost shifting to consumers. This can make using health insurance harder for low-income people in particular. And it frequently results in the deferral of critical care. Even in Medicare, this is a real and serious problem. Next slide, please. Another misnomer when we look at costs is that high prices somehow correlate to high quality. They don't. In our experience at CalPERS, this is the case across the board. Some of our lowest health insurance premiums come from highly integrated plan designs, which also tend to yield the highest quality scores. Our highest hospital costs largely correlate with the part of the state in which the hospital is located and not with any link to quality. We also haven't been able to find a correlation between cost and quality when it comes to physician services. There, the biggest determiner of cost is whether or not a service is delivered in or out of a network, one of our networks, not whether or not it's delivered by the best doctor or whether it results in the best outcome. Sorry, slide 11, please, or next slide. This slide really starts to get at what does drive our costs. This is the CalPERS cost heat map. The pink and red places are counties that are more than average cost. The blue counties are lower than average cost. The gray cells are places where we don't have enough data to tell where they sit, blue or red. Overall, there is a more than twofold variation between average costs and the highest cost counties when compared with those that are lowest cost. We attribute a lot of the difference in cost to competition. The lower costs in Southern California correspond with competitive markets that help keep prices low. By contrast, Northern and Coastal California has less robust competition and has been the more frequent victim of consolidation on the hospital side, particularly on the physician group side. 15 years ago, this map looked really different. When I left California for the East Coast, the Bay Area and the Sacramento area were lower cost than they are now by a chunk. A good amount of that change is attributable to consolidation. Dr. Scheffler, Commissioner Scheffler, I should say, is the expert on this area, so he can probably share some of his research if we get into this. Next slide, slide 12. Healthcare is a great example of why leaving things to the market doesn't always get a great result. All of the boxes represent key attributes of a high-performing healthcare system, and yet I'd argue that our current healthcare market don't reward or at least don't fully value any of them. Because of time, I'm not going to go into examples, but there are examples of all of these, of failures in all of these categories. I think it's helpful to think of payment reform as at least partially making up for market failures in these areas in particular. Next slide, please. And this isn't intended to be a comprehensive list of payment reforms that we've tried, but all of these would be included on the Greatest Hits album. Capitation also belongs on that list, but for some reason I neglected to include it here. Bundled payments and hospital readmission penalties predate the Affordable Care Act, although the Affordable Care Act leaned into both. Accountable care organizations were really the centerpiece of ACA payment reform. And while some cost control commissions have been around for a while, I really think of them as a more recent phenomenon. This is a very crude observation, but in general, I would say that bundled payments and hospital readmission penalties have been plagued by cost shifting and perverse incentives, and accountable care organizations have not yielded anything close to the results CMS was hoping they would. Some of the state-based cost commissions are more interesting, particularly the ones that try to address cost control more globally. One of the biggest challenges for payment reform is that our success with containing costs in some of these areas often results in cost drivers shifting to other areas. I think some of our reading over the weekend spoke to that. This is another way of seeing that last point. The cost containment in one area often just shifts costs. When we look across payers, we often see that healthcare systems tend to make up for losses or lower profits that result from doing business with a very efficient payer by charging other payers more. This was a famous, there was a famous article in the New Yorker written by Atul Gawande a little over a decade ago that President Obama famously shared with just about everybody in his orbit. In that article, Gawande used the Dartmouth Atlas data to write about places like McAllen, Texas, which were very high cost areas for Medicare, and contrasted them with places like Grand Junction, Colorado, which were where quality was much higher and costs were very low. Several years later, and this is what's represented in this slide, or partially represented in this slide, this work by Zach Cooper showed that when we look at private insurance, many of those same places that that Gawande highlighted, including McAllen and Grand Junction, look completely different. The high cost Medicare areas are frequently lower cost on the private side, but more problematically, many of the low cost Medicare areas charge higher prices on the private insurance side. If you haven't already, I'd encourage you to play with the health price database the New York Times put out a few weeks ago. It shows the same kind of cost shifting even within single markets and within single procedures within a single market. Incidentally, this the phenomenon of cost shifting makes for a very powerful argument for unified financing, which theoretically should curtail or even eliminate it. Next slide, please. Oh, sorry, we're 2 slides back. One more. So couple of considerations. One is that, and this is a point that Dr. Kronik made when in his great presentation, that the first part of this point, I'm making the second part of this point. So unified financing may create an environment that's probably creates an environment that's more conducive to cost control. But right sizing costs is going to require a distinct cost control strategy. So I think it is fair to characterize universal financing as providing important levers for cost control, but it doesn't solve the problem in itself. Second point, unified health system financing alone may not bridge the gap between the US or California health outcomes and other wealthy nations. Addressing drivers outside the health system is going to be critical. That's the point I made with the comparative slide about social spending and health spending. I'm going to leave the questions maybe for later on. I'm happy to answer any questions folks have or to turn it over to whoever is next.
Hey, Don, this was really terrific. Thank you. Do you mind? I know we won't go into them, but the questions that you put up, I think it's one of.
No, absolutely.
Yeah. Let's just go through them. We don't have to spend a ton of time on them, but I think they're really helpful to the commission. We'll pop this back up later, but do you want to just go through each of them for a minute? Thank you.
Yeah, happy to. Yeah, so the first one is just sort of thinking about the key strategies that we should be employing to right size health spending. Second is which payment models we should be we employ in our current health system translate under unified financing and which do not. So when I think about payment reform, you know, it's important to remember that these countries that have unified financing already also use payment reform, and some of the payment reforms, particularly some of the ACA payment reforms, were of tremendous interest to countries that already have unified financing. So identifying, 10 years later, which ones are potentially still powerful and which ones maybe less so is going to be important as we think about unified financing. The third, and this comes from my time at the Commonwealth Fund, but what should we be trying to steal from other countries, right? There are, not only is it the case that they've had single financing for a while and have been grappling with payment challenges for a while, but some of the things that they do, we should be stealing tomorrow. If it were up to me, we would be stealing some of the drug spending models tomorrow or yesterday. But just thinking about what's happening in the rest of the world and what we should be trying to take advantage of here. And then the last one is a little bit of a mouthful, but I'll throw it out there anyway. Understanding that much of what drives health status sits outside of the healthcare system. What is our strategy for improving health? Should our goal be reducing health spending to free up resources for, say, better social supports? or should we be trying to address other needs through the health system? And this is really a question about where the health system ought to end and or whether it should end, and how it fits with social care systems. There is a debate about how much of our lack of social spending should be made up for on the healthcare side. So should we be trying, for example, to create incentives in our existing structure to encourage health plans to invest in needed social supports, medical food, housing, home care, and so forth? Or should we be trying to create the most efficient health system possible so that we have the resources available for a more robust social support system, and then working on coordinating the two? I have a bias here, but I'm going to keep it to myself for now. Maybe if we're talking about this later, I will share it.
Great, Don. Thank you for sharing these. I want to call the commission especially, I mean, all four of them are important. Obviously, we spent a little time talking about four in your fourth question in our prior conversations, but there's so much more to say. I think that the second question is of particular interest to the commission in today's conversation. So we'll bring that one back certainly in our discussion. Don, really tremendous job. I think we really appreciate the expertise on this commission, people's current lives and their prior lives and what they've done in their careers, kind of bringing to bear the tremendous amount of knowledge and expertise, and then your bias and opinion based on all of that information and the work you do. So we look forward to hearing that. But Don, thank you so much for taking time to share with us. I want to then quickly move into our second presentation. Dana Safran, who is currently the president and CEO of the National Quality Forum, but before that was really a pioneer, someone who really focused on how payment and quality and equity can be transformed in Massachusetts. Dana, it's really a pleasure to have you and welcome you to the Healthy California for All Commission. We appreciated the readings that were distributed in advance of the meeting, and now give us a chance to hear directly from you. So I'll turn the mic over to you. Thank you.
Thank you very much. And I'm really very pleased to have the opportunity to talk with this commission today and see many familiar faces and even friends among you. So really the important work that you're doing, it's a privilege to be part of the conversation. Here's my roadmap for our conversation today. In my brief remarks, what I want to share with you is some of what our experience was while I was at Blue Cross Blue Shield of Massachusetts with respect to a global budget quality contract model that we implemented. For those that aren't familiar with the AQC, I'll share a little bit about that model and what it was aiming to achieve, then what it did achieve, including its impact on health disparities. And then I'll close with some perspectives that I hold on the issue that right now is very timely and important around adjusting for social risk factors when contemplating performance-based payment. And then we'll have some Q&A, though if I understand right, that will happen in a little while in a summary panel discussion. Is that correct?
Yeah, Dana, we'll as we've done, we'll do all the presentations, and at the end, we're excited for you to stay on, answer some questions, but also participate in some of the conversation that the commission will have.
Okay, that sounds great. So onward then. Here is just an important context setting slide, and Don's presentation was so important and powerful and had so much of the compelling international data as well as US data around the issues of cost and quality. In the beginning of 2007, why was it that Blue Cross Massachusetts set out to develop a new payment model? And the answer to that really lies in the fact that we were in the early months of implementing our coverage reform law, now very famous because it became the basis for the ACA. And we knew that cost was next. We knew that both because the framers of our state law had deliberately deferred trying to build cost control into the legislation, feeling that if they tried to deal with both access and coverage as well as costs, that they might get nothing done. So they chose to deal with access and coverage first, but knowing that that would compel further action on cost. We also knew it because the law was going to, for the first time, require individuals who didn't have insurance through a government program or through an employer to go into the marketplace and buy insurance for themselves. That all sounds, very quaint now, so many years later, but in 2006 and 7, that was a brand new concept. And what we knew was that Massachusetts citizens who did go ahead and buy insurance for themselves were going to begin to come face to face with the graph that you see here on this slide, which is that the rate of rise in healthcare costs is many-fold higher than the rate of rise in general inflation as well as in workers' earnings. And they would appropriately ask very hard questions about why is this? Why is it that healthcare is growing in double digits when my wages are certainly not, and nothing else that I buy in my day-to-day life is growing at that rate? And so our senior leadership said we need an answer to that. And I had the privilege of being part of a very small group that was charged with sequestering for 10 days to come up with a new model that we could offer as voluntary for providers in our network to be paid in a different way, and that model should accomplish the twin goals of improving quality and outcomes while significantly slowing the rate of growth in healthcare spending. So just the holy grail of improving quality and outcomes while slowing spending growth, 10 days, go to it. And what we came up with, we called the alternative quality contract. Had we known it would become such an important model in not just the local, but the national and international discussions, we probably would have sent it to our marketing teams. But nonetheless, we called it the AQC. And so let me share on the next slide a couple of things about the AQC that were distinctive at the time. Again, remembering that this was 2007 and before the national conversation about payment reform was underway. In fact, just to place it in time for this commission, before we were using the terms patient-centered medical home, before we were using the terms accountable care organization, that was the time frame. And so what we came up with was a model that would be distinctive from our traditional payment models in 5 ways. The first was that providers who came into this model would agree to be accountable for a patient population for every aspect of their care from end to end, from prenatal care to end-of-life care and everything in between. And they would be agreeing to be accountable for the cost, quality, and outcomes of that care. So, pausing there, and I know this commission understands that, but I would just underscore that that is 180 degrees from what providers in a fee-for-service model are accountable for. In the fee-for-service model, our providers were accountable for the patient in front of them for as long as that encounter lasted, whether that was an office visit or a hospital stay. And when the encounter was done, the providers would submit the bill, and that was the end of their responsibility. And part of what is so profound about global budget models is that they do require providers to begin to think outside the literal and figurative box of the practice setting to where patients live and work, and to those social factors as well as behavioral and health variables that will together influence the outcomes of care and further utilization. And so, so this single change is tremendously important. A second distinction between this and prior contracts is you can see it was a 5-year contract. Typically, our contracts were anywhere from 1 to 3 years. So 5 years was a long period of time. We understood that in order for providers to actually be willing to invest in organizing care differently and having a new information system infrastructure, new staffing models, there was going to have to be an understanding that this model would endure, not that, you know, there might be a next flavor of the month coming along in a year or so from now. Third thing that was distinctive is that the model was based on a global population-based budget, and that's represented by the dotted line going across the middle of the chart here. We made the decision that that would be based on the historic rate of spending for that provider's individual patient population and not a dollar less, right? So, you know, it would have been fair, acceptable for us to say, look, there's enormous evidence of waste in healthcare, up to 1/3 of medical spending not producing value. We're not going to take 1/3 off what you've been spending up to this point, but, you know, we're going to take off 1% or 2%. But we understood that if we came to the table with that value prop, and this is a voluntary model, we might be still sitting here today waiting for our first providers to adopt into the model. In addition to that, and also very important in our thinking, there was, and I believe to some extent, to a large extent still is, very much a culture in the US of more is better when it comes to healthcare. Very much a suspicion that, you know, less care, especially if it's because a model is incentivizing it, is something to be afraid of. And so, so we felt it was critically important to set the budgets right at the level that was the rate of historic spending for this patient population, with all of the complexities and everything else baked in. And then to create the incentive for providers to find where there could be opportunities to save from within that budget. So that's what's represented by the blue shading underneath the line. And those were two-sided risk contracts from the beginning. None of the AQC contracts over time have ever been anything other than two-sided risk, symmetrical. And so that was that third piece. Fourth piece was that inflation on that global budget was negotiated before the contract started for each of the 5 years and set to decline over time, so that by the 5th year of the contract, the rate of growth should look like the general inflation that we saw in the previous slide. And then finally, importantly, what's represented here by the gold, somebody changed some colors in designing this for me at NQF, so I apologize. But in any case, the fifth component is an earning opportunity, significant earning opportunity on a broad set of quality and outcome measures, up to 10% of a global budget. And so, you know, if a typical budget was at that time about $350 per member per month, that means, you know, up to $35 per member per month times 12 months a year times at least 10,000 members required in order to have actuarially sound budgets meant that, you know, there were millions of dollars in upside earning potential based on quality performance. So that's how the model was different. And again, like my comment about coverage reform earlier, this may all sound, you know, quaint and like, you know, absolutely, of course, but these were brand new concepts at this time. And in particular, the idea of building in a broad and robust quality measure set as a counterbalance to the incentives of a global budget was really very new. the 1990s had really created a lot of fear around the potential for providers who had a budget constraint to stint on care. And we saw the quality measure set as a really important opportunity to serve as a backstop against that impulse to stint on care. So next slide just gives you an overview of what that quality measure set looked like. What you'll notice is the measures included ambulatory and hospital measures in order to reflect that continuum of care that a provider would be accountable for. And for both of those settings included a set of process, outcome, and patient experience measures. What I'll draw your attention to is that on the ambulatory side, the outcome measures were triple weighted. First of all, the fact that there were outcome measures was noteworthy at the time. You know, pay for performance was really just getting started. Not a lot of success had been found, typically very small dollars attached to it, lots of process measures, not even very much in the way of patient experience measures, but outcome measures were not part of, you know, performance-based payment for providers. So, you know, I, as a person responsible for developing this part of the contract, kind of came to the table for our early negotiations with a lot of talking points ready in my back pocket about why providers should be willing to be accountable for things like control of hemoglobin A1C, control of blood pressure for patients with hypertension, cholesterol control, and deal with their questions and concerns that, you know, how can you hold me accountable for what happens outside of my clinical practice? Interestingly, our early adopters were really very ambitious and mission-oriented, and were the ones that said, these are your most important measures. If we could reach your highest levels of performance on these measures, that would be something really profound for the public's health. And so you should make them count more. And that was how they came to be triple weighted. Now, I'll just share as an aside, but maybe an important one. Part of why I got interested in this role of leading NQF and why I'm sitting here today is because I think it is outrageous that our quality and accountability models, our value-based payment models, have roughly the same measures in them today that our AQC contract had in 2007. There's just not enough coming through the pipeline that fills the critical gaps that private and public sector payers and purchasers need in order for value-based payment to actually deliver on the promise of better outcomes at lower cost. And so, you know, it is one of the really important pillars of what I aim to accomplish at NQF is to do the multi-stakeholder work that helps us get to that next generation of measures required for value-based payment to be successful and sustainable. But let's move to the next slide. Here's a little bit about the results that we achieved. And I know I shared a couple of articles about this. But here what I'm showing you in this slide is taking apart that, that measure set into a few different pieces. Adult chronic care, which is the process aspects of ambulatory care, pediatric care, also process aspects, and then those outcomes that were triple weighted. And again, my apologies, there are some changes that someone trying to be helpful to me made in these slides that are incorrect. So in each of these, the top line should be labeled BCBS MA AQC, and the bottom line should be the non-AQC results. So, sorry, it should be the HEDIS national average, the benchmark at the bottom. So there shouldn't be color differences there in all three of those panels. The top is the AQC performance and the bottom is the national HEDIS benchmark. And so what you notice is an improvement story across the board, but in particular, the improvement story on outcomes, I think, is the one that is so profound because as I was mentioning earlier, you can't accomplish these kinds of changes without thinking about patients outside of the clinical setting. These are the things where patients have to actually change behaviors, take medications, change their diet, work on stress, work on exercise, et cetera. And what you notice is that in 2007 and 8, before the contract started, our providers were at the same abysmal point as the national average. And very quickly, those who were in the contract were able to improve to where 3/4 of adults with chronic illness were under good control. And just to, remind us what poor control means for these conditions, the fact that we've got less than 2/3 of adults nationally in good control means that these patients are at risk for going on to heart attacks and strokes, kidney failure, blindness, amputation, death, terrible, both from a quality of life perspective and from a cost perspective. So a really important accomplishment to be able to help patients get to better control. How they did that was to begin to actually practice patient-centered care, right? To begin to actually think about my patients outside of my setting. What are the barriers? Are they cognitive barriers? Are they practical barriers in the environment? Are they motivational barriers? Are they financial barriers? What are the barriers to this patient doing what is going to be needed to have their condition be under good control? What can I do to help them manage that? Next slide shows you that another really important byproduct of that was that we, for the first time that I'm aware of anywhere, we're actually able to begin to close some of the longstanding disparities in care associated with socioeconomic status. So how do you know that? So you see the yellow versus the green line is the patients who were in AQC contracts who had higher socioeconomic status contrasted with those in AQC contracts who had lower socioeconomic status. And if you look at those trend lines from 2007 to 2012, you see the narrowing of that gap, the closing of disparities. And what you notice with the other two pairs of lines, both the non-AQC, which is the blue and the orange, and the low regional and national averages, that those closing of the gap was not otherwise happening, right? So those trend lines were parallel. They, were not really changing, but you can see the upward trend line on that green line of AQC lower SES populations. That was really helping us to narrow that gap. What I'll talk about finally before I close is that led me to have the very relatively strong point of view, quite strong point of view that I do today about the issue of adjusting for social risk factors. In this model, we did not adjust for social risk factors in performance. In fact, before the model launched, I really thought very hard about that issue. It was not part of the public discourse at that time, but I thought, is it really fair to hold providers accountable for the same level of performance regardless of who their population is? And in the end, my answer to myself and to our network was, I could not get comfortable with facing out to our member population and saying, I have set a lower standard of care for you because you're poor, because you're a person of color. I couldn't get comfortable with setting a different set of performance targets based on who the population was. So we had the same performance targets for every provider. And what we saw, and part of what was captured in this article by Zuri Song and others, was that providers who were serving a disproportionately lower SES mix actually had higher gains in their quality scores over the contract. Even in the very first year, two of our providers in particular who served a disproportionately lower SES mix went from near the bottom of our network pre-AQC to near the top, well surpassing some of their peer providers who served a largely advantaged population, and stayed there. It was not a one-time chance event. And so if you go to the next slide, I think it's my last. Oh, sorry. So this, I won't spend time here, but you know, we had the enormous benefit of a team at Harvard Medical School that was tracking what we were doing while we were doing it, even from the very first year, studying the impact on cost and quality in a very rigorous way. And in the 8-year outcomes results found that 10% trend savings on average had been achieved through the AQC relative to the counterfactual of the absence of the AQC. So going to the next slide, just back to the social risk issue. I don't recall if I included this in the background readings, but the citation is there. And what I would offer to you as something to consider is that when it comes to addressing social risks, that we should be adjusting payment, not performance scores. That is, those who are serving a disproportionately lower income or higher social risk population should receive either greater resources to apply to the care for that population and upfront, and or enhanced performance payments based on the degree of difficulty of achieving a given level of outcomes for a population that has higher social risk. In that way, we can think of it as investing in health equity, as opposed to adjusting the measure scores, which would essentially be accepting the status quo. So that is all I have for you in my prepared remarks. And I very much thank you again for the opportunity and look forward to the conversation in a little while. Thanks.
Dana, thanks so much. Terrific presentation. Really helps to have somebody who's done it for real and struggled through it. And it's great. You kindly said things of today have become more normal based on, but back then we're really trailblazing. And I think we're grateful for your work in Massachusetts and how it's impacted us here in California. I want to go to the next speaker. Josh Sharfstein, Bob and Richard Pan, another pediatrician. So that makes 4 of us on this presentation today. Josh is was very busy and active in Maryland, has held a number of different roles throughout both state and federal government, and has also really been a pioneer in working across sectors, not just on health care sort of service delivery, financing, but in so many other areas, really worked on substance use disorder issues, childhood asthma issues, and a number of very important areas. So Josh, really a pleasure to have you join us today and share a little bit about your Maryland experience and where that's taken not just Maryland, but other states as well.
Sure. Thanks so much for having me, Mark. And thanks for doing this. And thanks to all the commissioners for spending time to, rethink how to get the healthcare system to work better in California. I really have to just mention that Dr. Pan was one of my teachers in residency. So it's always great to be on any kind of, formal process with him. And also, I have to give a special thanks to Peter Lee for his incredible leadership for exchanges around the country, which we benefited from immensely in Maryland. And finally, for Andy Schneider, because he answers every question correctly as soon as I put it to him over the last 15 years at least. So it's great to be here to see so many people I've worked with before. So I'm going to talk a little bit about Maryland, and maybe I can share my screen here. I really have just a few slides, and I'm going to try to be kind of short because I prefer the, let's see if this works.
Dr. Sharfstein, are the slides that we're displaying now the ones you'd like to
Oh.
share?
You have the slides?
Yes.
Okay.
Yes.
Let me see. You beating me to it. I'm trying to see because I like have all my screens showing my stuff. I see. There you go. Sure.
Great.
We can go with that.
Wonderful.
Excellent.
You can just let us know when to advance the next slide. Thank you.
All right. Very good. Very good. No problem. I'm like, I can do, and I've learned to be very self-sufficient during the pandemic for remote presentations here, but I'm totally happy for you to do that. So I think this builds really well on what Don and Dana have been talking about. I really appreciate the chance to be with both of them. I always learn from them, and I did today. No matter how many times I read what they've written, it's just so helpful to hear from them directly. So I'm going to talk about Maryland, which really brings in both some of what Don was talking about and some of what Dana was talking about. Don was, talking about how poorly the United States does, not just in terms of cost, but in terms of health, and how there is a chance when it looks like things are going great for one payer that they're going kind of terribly for another payer, and you have to take a look at the full picture to see whether a healthcare system is functioning. And Dana talked about the advantages of going to a global payment that they saw with Blue Cross Blue Shield in Massachusetts. So Maryland kind of brings those two things together because we have been thinking about healthcare for the entire state at once for all payers, for Blue Cross, for Kaiser, for Medicaid, for Medicare. Maryland has done a lot with all payer reform, and this has been going on since the 1970s, but it's the more recent kind of innovations I think are probably most interesting to you all in California. So just, to explain why Maryland's different, since the late 1970s, we've had rate setting for hospitals. And rate setting is there's a commission that basically gives a rate card to each hospital. And Hopkins might get a different rate card, or does get a different rate card than the Anne Arundel Medical Center. But once Hopkins gets its rate card, then everyone pays those rates. Medicare pays those rates, Medicaid pays those rates, Blue Cross pays those rates. And so that's how it started in the 1970s. And it evolved. It was pretty exciting for Maryland because Maryland had the ability to set rates for Medicare. So Medicare paid Medicare rates in 49 states in the District of Columbia for many years, and paid Maryland rates in Maryland. So it's pretty exciting when you get to set Medicare rates, but it came with some strings attached. We didn't just get the keys to the federal treasury. And the two strings that were attached were that all payers had to be treated equally. So Maryland's payment commission couldn't say, it's kind of harder to take care of older people, so let's triple the prices for people who are older. Medicare would say that foul, can't do that, this whole system ends. But the second thing is that Maryland's prices couldn't rise faster than the national rate of growth in prices. And that was the concept, like, okay, your prices might be a little higher in Maryland, but we're not gonna let them grow any faster. And that kind of, was the fuel for Maryland's interesting fee-for-service system, still fee-for-service, but where every hospital basically got a rate card. And there was no difference between what Medicaid, Medicare, Blue Cross, Kaiser, or the uninsured paid for hospital services. That takes you to 2014, when one of those strings began to pull on the system, and Maryland couldn't keep its prices growth down, couldn't keep the price growth down. And that led to a real crisis in the system. Would we even have a rate setting commission? And that happened to be when I was the Secretary of Health, and we had to rethink the entire system. And working with the hospitals and many others, we decided to try something very different, which is global budgeting. So now we're getting to the global part. And the idea is, again, across all payers, instead of giving each hospital a rate card, we give each health system a budget. And it's negotiated, and that budget is good for the hospital expenses for the year. And basically, this is, as you get into this, it's sort of the darker shades of blue on the slide here. Basically, the hospital knows what it's going to get a year in advance, And therefore, if they actually prevent illness, they get the financial benefits right away. It's a much stronger alignment of the health of the community with the financial health of the hospital, because the hospital gets the benefit if fewer people get really sick. And if you think about all these different communities where you have this weird, situation where you have terrible health outcomes, very high disparities, and incredibly high costs, because all these people are having preventable heart attacks and strokes and cancers. This has a different approach, because in those systems, the health systems get paid an awful lot. In a global budget approach, you have a much stronger alignment that if you can actually prevent those heart attacks and strokes and cancers, then the health system will do better financially over the long term. That was the basic idea. And so if you go to the next slide, here's the explanation. Fee-for-service hospitals are very expensive. I was just looking at the Onion where it said something like the motto of the US healthcare system is there's an extra charge for that. And that's the motto of fee-for-service. But in addition, if you can't get the beds filled, then you have to close your hospital. And so there are hospitals under incredible financial stress because they can't get sick enough people. And you have a situation in many parts of the country where hospital executives are going like, what can we do? What service can we start that will allow us to fill the beds? And in a way, they are surviving. The only way these hospitals have to survive is to find more sick people in their communities rather than make their communities healthier. So there's just a fundamental disconnect between fee-for-service reimbursement and the health of the community. By contrast, global budgets stabilize the hospitals and allow them to shift services on community needs. Like hospitals have, crazy reasons for why they grow some services or not. It has a lot to do with reimbursement. And this is where people, talk about patients by their body parts. Like, do we need another kidney service, or do we need a lung service, or do we, as opposed to what does the community need to stay healthy? And when you have a global budget, you can have that conversation. It creates a way for hospitals essentially to make money through prevention and investing outside the walls of the hospital and making partnerships outside the walls of the hospital in order to be successful under their core payment model. Not like a side community benefit kind of plan, but their core payment model, their core financial success depends on being able to prevent unnecessary illness. Next slide. So what have we seen? We put every hospital on a global budget, basically, in Maryland, negotiated with them. They were all excited to do this. It preserved our system of rate setting. So we see a bunch of things right out of the gate. Care redesign. So we did a whole series of interviews with CEOs in Maryland, and one CEO, very traditional CEO, said, we started asking ourselves, why don't we have social work 24/7 in the ER? Why do we give prescriptions and not the medicines? Why do we give phone numbers and not the appointments? We need to be like much more responsive in how we actually get people to care, because we truly don't want them to come back. One CEO told me that his previous motto was something like, we'll always be here for you, the hospital. And in the new motto unofficially was, we hope to never see you again. That's what it means to switch to a global budget. Coordination with primary care becomes incredibly important. And CMS has given Maryland the ability to have a bigger and bigger primary care model as a partner to the hospital global budgets. Regional prevention efforts. So there is a project called regional partnerships, where some of the money from basically the hospitals put some money in. They're allowed to increase their rates a little bit and their budget, and then some of that money gets put into a common pot for investments. And one of those is housing investments. Another might be linking people to social services. There's a multi-10 million, I think it's like $50 million effort to improve behavioral health care in the Baltimore region, all funded through this effort, none of which I think would be possible under a pure fee-for-service arrangement. Next slide. I'll just actually go back one slide. I just want to give you like why this is really different and a completely upside down way of thinking about healthcare. When I was the health secretary, and Mark, I'm sure maybe he won't say this, but I believe he will believe me that his day is not filled with good news all the time. Sometimes when you're the Secretary of Health, some, not so good news comes your way. And so I was sitting as a Secretary of Health in Maryland, and in came somebody to tell me about the latest crisis. And it was because the school system in one of our counties had fired all the school nurses who were in the health department. And I couldn't tell you then, and I definitely can't tell you now, why they were fighting. But it was like a disaster because they had fired 60 or 70 school nurses. People were screaming, they're not allowed to open the schools without the school nurses. It was just like a total chaos. And in the middle of me trying to wrap my mind around that, maybe this never happens in California, but I was just saying, just speculating here, that the phone rings and it's the CEO of the hospital in the county, and one big hospital in the county. And he calls me and he goes, I just want to let you know, we're hiring all the nurses. And I said, why are you hiring the school nurses? I've never heard of the hospital hiring all the school nurses. And he said, well, Josh, we've looked at our data really carefully under our new global budget. We have so many kids coming into the hospital for asthma. We think we can run the school health program break even and reduce the number of kids coming to the hospital, make all this money on the back end, and it's good for the community, it's good for us, and we're going to make that happen. And that's what they did. They hired all the school nurses. They're still hired by the hospital. But that, just to give you a sense of how, why he would do that, why he jumped in to do that, that it's the global budget that makes that possible. Next slide. Overall, Maryland did pretty well. The first 5 years of the model had nearly $900 million in total cost of care savings compared to the national growth trend. There were multiple independent reviews that were done. The cost results were very good. Some of the outcomes included big reduction in complications, better, huge steep drop in readmissions. We also saw nearly a 10% drop in preventable admissions in the Medicare program too, because there was a huge focus on preventing unnecessary admissions. Next slide. This is from a big evaluation that was done for CMS by RTI. And these are some of the conclusions. Hospitals were able to operate within their global budgets without adverse effects on their financial status. If it's a good enough budget, there's so many ways for hospitals to improve their margin. It doesn't, in the United States, did not stress whether they had enough money to provide adequate services. Admissions for ambulatory care sensitive conditions declined, as I said, in both the Medicare and commercial populations. Low-income Medicare patients and those with chronic conditions had more favorable outcomes. And keep in mind, this is everyone in the state. This isn't some group of patients in the state, and who knows what's happening to the other group. This is everyone in the state. Now, there are definitely things that Maryland can do better, and one of them was cited in this report: need for additional coordination with community providers, particularly in areas like behavioral health. And that was one of the reasons, after we got this, that the system came together and said, let's put like $40 million into trying to fix the behavioral health system in the Baltimore region. Next slide. So this is my final comments. I believe all payer global hospital budgets are a viable health policy reform. This was proposed by a Democratic governor, approved by a Democratic president, reproposed by a Republican governor, approved by a Republican president. It has very, very strong support within the state of Maryland. There are not that many, statewide health interventions that have that kind of support. An important benefit is stabilizing financially vulnerable hospitals, which matters a lot to communities. I will say that incentives alone, like even very powerful incentives, do not necessarily lead to changes in care delivery, but I do think that they can help. If you were to say, what could you do differently if California were to consider this, I would say you should consider pairing global budgets with plans for care delivery transformation upfront, with metrics covering not just all those quality things that you might hear about, but community health outcomes based geographically and health equity. And finally, I do think that the alignment between hospitals and their communities can help benefits well beyond clinical care provided inside a building, because once you open hospitals' minds to the fact that they'll actually do better if their community is healthier, there are all kinds of things that they may get themselves involved in for fundamental, reasons. So I'll stop there. Thanks, Mark.
Thanks so much. I just want to take a moment to thank all three of our presenters, Dana, Don, and Josh. Really great set of presentations. I think gives us a lot to think about. I'm going to start off with one question to Josh, and then I'm going to pull some of the commissioners in to ask some questions and answer some of the questions I have for them. Sandra Hernandez, I'm going to come to you first because I know your foundation has done a lot of thinking through how payments for a whole set of services in California and beyond can be used effectively to transform what we get from those dollars. And so hope you will share some of your thoughts on how today's presentations reinforce or alter kind of where you and your team has been thinking, and then ask some questions of our presenters. But Josh, the Maryland experience is one that many of us have heard a lot about. It informs so many different things. You mentioned how Peter's tremendous work at the Covered California has helped impact what the rest of the nation has seen on their exchanges and innovation. Maryland, I think, has done that in this same regard. I guess one question I have is, what has prevented the Maryland experience from really being scaled? I know that you've shared a little bit about what's happened in Pennsylvania since, and maybe some other states, but it hasn't taken off across the rest of the nation as much. And then one of the struggles that I know we have is so much of the hospital global budgeting was really focused initially, at least, on some of the rural hospitals as a strategy to support and stabilize them in a state where we certainly have that challenge, but also a lot of urban centers with hospitals and systems right across the street from one another taking care of the same patients. What's your advice on how to apply some of those strategies, or how you've seen those strategies work out in some urban settings? So I'll start with that question and then go to Sandra, and then we'll just pull in the rest of the commission to ask questions and provide thoughts.
Sure. So I tease out two parts of that question. One is, why hasn't this spread further? And the other is, how do you do this in urban areas? Just to be clear, and they're related. I think I think that it's important to realize, for a global budget, you're really trying to shift the hospital's thinking to the population. It really helps to have all the hospitals serving that population facing that same set of incentives. It's very hard. If you imagine like a fee-for-service hospital across the street from a global budget hospital, you could like imagine like the moving walkway that just takes patients from one to the other, or the sound of just the patients getting vacuumed from one to the other. And it's really hard. You want everybody focused on improving the health of the population, and the healthcare system generally across hospitals really working in tandem. And in Maryland, we have that. We have a phenomenal health information exchange, which the hospitals all share all this data for, and they get all kinds of alerts and other things. I could go into it in great detail. But the reason that exists is because all the hospitals are facing the same incentive. So if you believe me there, then you could say, well, okay, well, an area that just has one hospital, you could do this. And that's what happened in Pennsylvania. Rural areas are able to do global budgets. And there's interest in different places in doing global budgets, where, because you don't, if you need all of the hospitals in the area on a global budget and there's only one hospital, it's not too complicated. And there's a lot of interest in a number of different states and rural areas. And the federal government actually adopted a model for rural areas that's very much based on this, called the CHART model, that they're trying to work their way through. There's some challenges there, but I think there's very much progress on the rural thing. So then why hasn't this taken off in urban areas? And I think that one of the major challenges is you have to get all the hospitals. And you can have two hospitals really struggling under the current situation, and one or two hospitals doing incredibly well under fee-for-service. These are the hospitals with enormous market shares that kind of can dictate prices and essentially print money in the basement. And I've given talks on global budgeting in some of those hospitals, and it doesn't go well. It's like I'm a comedian, nobody's laughing at all. Nobody is interested whatsoever. It totally like blows their mind. I get hit from the right, I get hit from the left. People just are completely, agog at the idea that we might put an overall amount of money for the hospital. And I think it's just really hard to get hospitals enthusiastic if they are on the traditional way of making a ton of money, frankly. And I think that makes it very hard for this to spread to areas where you'd have to get a bunch of hospitals in the same area. Now, having said that, it can be done. And there are parts of urban, for example, urban settings where all the hospitals in a particular region are kind of struggling. And so people are open to doing things differently. And I'm aware of and involved in trying to help places like that do some version of global budgeting, but it's because you've got that. But if you take a city with, some hospitals, and I'm sure we could all think of some that are just doing sensationally well financially, going in there and going like, great idea, guys, we're going to put a cap on how much you are going to make next year. That is very, very hard for them to hear. Now, how you do it logistically was kind of your question. I'll just say 2 sentences about that. Maryland does that. We have multiple hospitals in different regions. There are models for doing that. And basically, you are looking at the hospitals and where patients are going. You're not attributing individual patients to hospitals, but you're looking at shifts between hospitals. And so if patients are moving to Hospital A's budget is going to grow over time. And if patients are moving to Hospital B's budget is going to grow over time. And you're particularly looking at non-preventable admissions. Everyone has the shared incentive to reduce non-preventable admissions. But if you are doing a better job with a particular service and more people are coming, then we will eventually grow. And so there's a reference population so that is for each hospital, and the commission looks at shifts in what's happening across multiple service lines, and based on that adjusts the budgets year over year. So it can be done. It has been done. I don't think that the technical part of this is what's inhibiting the growth to other areas. I think it is that there's just going to be people, as long as they're making a lot of money on fee for service, it's going to be hard to get all the hospitals in a region to really go for global budgets.
Thanks, Josh. We'll go to Sandra, you first, and then maybe I'm going to go to Peter Lee next, just given how much I know you've thought about how payments drive what we want out of our health system, and your tremendous work with plans, which we didn't really talk about, Josh, or others. I know Dana did, but Josh, the role of plans in some of this. So I'll leave that, Peter, for you to think about and provide some thoughts on and ask some questions. And then Richard Scheffler will go to you next. Karen, at some point, maybe not right now, but soon, would love to pop up the slide with Don's 4 questions again, because I want to make sure the commission keeps those in mind. I thought they were applicable broadly to this entire conversation. So if we could pop those back up for the commissioners and everyone to see in just a moment. But Sandra, thanks for allowing me to put you on the spot.
Yeah, no, thanks, Mark, and really Don and Dana, Josh, really fantastic presentations all the way around. Just to react to a few things, Don's question around, where should the healthcare system end and the social service system expand, seems to me to be a really profound policy question, right? Because even if we decided, well, we should invest more in social services, which is, I suspect, Don's bias. Yeah, you gave it away, Don. By reducing healthcare costs by policy does not necessarily mean we would expand social services costs, right? I mean, having run a county, you could reduce, costs in jail health, but you don't get that money back in some other capability. And so to me, that's sort of the conundrum with regard to what is really a profound problem that we have in the country, which is we're spending a whole lot more on healthcare and really wildly inadequately on social services. So I don't have an answer to that question, but I think it is a very important policy one. On Josh's presentation on hospitals and how hospitals behave, I mean, to me, one of the most important aspects of that is that it sort of didn't matter if you were on Medicaid, or in our case, Medi-Cal, or in a commercial plan, or in, whatever particular form of coverage it came in. And in California, of course, we have this problem that, Medi-Cal pays rates abysmally low for providers. And so you get this perverse notion of, well, I'll take care of more Medi-Cal, but then I'll cost shift to another part of the system. And I think it's super compelling what Josh describes, which is it didn't matter if you were in Medicare or you were in Medicaid or you were in a commercial plan. Really, it was in a hospital's best interest, based on how hospitals were compensated, to care for all of those patients equally. And it seems to me that is at least one way to think about how we address this problem we have with Medi-Cal provider rates. And we could talk about provider rates a lot, but they do create all kinds of challenges for our goal of health equity, of reducing social disparities and outcomes in general, given that you have all this cost shifting that goes on in these really perverse incentives. So, the global payment to hospitals, to me, is an incredibly elegant solution to at least that one problem that we do have in California that I think is, stands in front of our ability to really achieve health equity. And then, just to name, the investment in prevention and how we get there. Dana's numbers there were astounding, right? To look at them, 4% or 2% investments in prevention. And this really speaks to our public health problem, right? How do we think about the dollars that we spend, and how do we shift those into a much more prevention-oriented, outpatient-oriented, primary care-oriented system? And I think we took lessons really from all three of our speakers this morning, Mark, on that. And then the last thing that I would just say, because it was mentioned briefly by Josh there at the end, about a $40 million investment in the persistent behavioral health challenges. CHCF did some work within CQA to look at how you might address the incredible challenges that we have in behavioral health in the state, behavioral health integration, behavioral health in general. And, it seems to me in all of these models, there's still a lot more to learn about how we use payment to actually significantly address the outcomes, quality of life, and disproportionate mortality we have in particular for folks with serious mental illness who died, of course, many decades earlier of arguably preventable physical health issues. So that one, I think, Mark, we need a lot more look at as a commission, because to me, it's an area where there's experimentation, but not a lot of research about what works. So I'll stop there. I know Dr. Scheffler wants to get in here on, I hope he'll talk a little bit about Southern California, Northern California, and the challenges we've had in that space. So hope that's helpful, Mark.
Thanks, Sandra. So before Richard, I go to you, I wanted to put Peter on the spot, and then Richard, and then Anthony, I'll talk to you, ask you to, you've raised.
Anthony, you get to make up what you think his question was.
Secretary Galley, you've cut out. I wonder if you want to turn off your camera to try to save some internet. You are frozen. I think we've lost him temporarily.
Peter should just Peter jump in. Yeah, please.
I'll jump in, and I'll give Anthony his assignment in a moment, which he'll do a great job with. First, I really can't second strongly enough Sandra's note. The three of you, Dawn, Dana, Josh, great presentations. And it's sort of saddening to me, however, is all of you are really clear, and much of this information we've known for 20 years, and we're still in a pretty crappy state in America's healthcare system. So that's just a note of some point of frustration. Just a couple flags that I'd note is one, and in particular, Dawn and Dana flagged the importance of our looking at cost, always with a quality lens. Lower cost does not mean worse quality, higher doesn't mean better, but if we aren't looking at quality, we aren't looking at a value question for the consumers we're serving or not. And I think the other reminder note I've done looking at this a good bit is that we're still really bad in America. And it's not just relative to other countries, but Beth McGlynn says we're still at about coin toss healthcare. Your likelihood of getting the right care at the right time is about 60%. That's really bad. And it is worse in some communities of color, it's worse, et cetera. So that's one observation I want to reinforce. The other that I'd flag, and this is where I really appreciated Dawn's queue up of the questions for us of right sizing. Sandra's right, there's a huge question about social spending and health spending. But within health, it's not just about a right sizing, it's where are we spending? And so how do we have payment systems that, as Sandra alluded to, that seek to do what our system doesn't do? We don't reward providers or delivery systems for doing things that aren't high margin. We don't reward primary care. We reward interventional things. We don't reward prevention. We don't reward care coordination. We don't reward navigation, promotores, et cetera. This is independent of unified or not. We don't have payment systems that put a thumb on the scales. Now, we are seeking to do that at Cover California. But I think the main flag that I would note is this is a multidimensional problem under any meta financing system, because in the end, you're paying doctors, hospitals, medical groups, pharmacies, and whether NICE is the right frame or not, I think we need to be looking at payments that actually consciously put the thumb on the scales towards things like primary care, towards RX, that is not just about the newest thing that a pharma company can charge 80 grand for, but is things that are doing better for more people. And so those are some of the challenges I think we all have, but it was a great setup. So I'll pass it back to Mark to queue up Anthony's question.
All right, Anthony, we'll come back to you in a second. Richard Scheffler, I want to go to you next, and then Anthony, and then Richard Pan, and then I'll pull in some others.
Well, thank you, Mark. I want to start with a shout out to David Card at Berkeley in the economics department that got the Nobel Prize for economics. David has also done some work in healthcare. Unfortunately, they also gave the prize to a Stanford professor. So why do I bring this out? Why do I bring this out for this committee? It's an example to show that in the United States, a public and a private model can both produce excellence. And in the commission's thinking about healthcare, I hope they use that lens. Don gave us a terrific presentation, and now I'm going to put my professor hat on. We need to pay attention looking across countries about how they do accounting. For example, in the United States, you know, the healthcare budget includes nursing homes and home health care. In most of Western Europe, that's in the social services budget. So you need to look at that data more carefully and do an apples to apples comparison. It's still going to produce the result that you came up with, that those countries spend more on social services, but the numbers will change significantly. And even more so in the Medi-Cal program now, when you pay for transportation, which is not a health service, that would generally be paid for in a social service budget. So you're exactly right. That balance is important, but we need to be more precise in looking at it. You're clearly right that the prices matter. And we know a lot about what happened in Northern and Southern California and the now well-known Sutter case, which was settled for $575 million, where Sutter had a huge impact on raising all of the prices in Northern California. But spending is more than just price times quantity. Spending has to do with the mix of services. For example, primary care or high tech or low tech. And the technology in California explains a lot of the cost variance that the commission needs to consider. This shows up when you look at the spending in the hospital, the percent of the total spending in California that goes to hospitals. That's 36%. In the US is 33%. 3% matters a lot because most of the money in the healthcare system is spent in hospitals. This also shows up in physicians. In California, 26% of the budget is spent on physicians. Nationwide, it's 20%. So I agree with what you said, but I think there's more to the story. But I take my hat off to you to bringing those points up. I love Dana's work and have followed it for years. She's also worked with some of my colleagues and friends in Massachusetts. I think she's totally right to think about adjusting payments for disparities and the impact it would have on reducing those disparities. So hats off to you. And I know in your new position, you'll be getting other states to consider doing the same thing. I don't know Josh, but I know his father quite well, having worked with him. It's a different generation. So say hello to your dad for me. And I've learned a lot from him, and I'm finding I'm learning a lot from you. But again, I like the idea of budgets and global budgets, but I'm going to put my professor's hat on again, I'm sorry, and ask some critical questions that I hope you can help me understand. So the first one would be, as an economist, if it's such a good idea, why aren't other states doing it? Second question is, a lot of the success of Maryland, you must admit, was getting that waiver that Medicare was willing to pay Maryland prices in Maryland. The chances of California getting that now, I'd like your assessment. Maybe Andy can tell us and weigh in as well, and others, and Carmen. It could happen, but I think it would be a big lift. Then I ask you, what happens if a hospital runs out of their budget? I can't believe in all these years there wasn't one hospital that overspent its budget. What happened? What was the political process? Did you fire the hospital administrator? Did you shut the hospital down? I bet you gave them more money, because that's what happens in the UK when they set a budget. Every year, about December, hospitals and communities run out of money. And then there's a political process to help them out, because they're not going to shut the hospital down. So I love the idea of global budgets. You called it global revenues. I will take a more careful look at how you actually set the budget, which I'm sure was a combination of analytics and politics. And maybe I'll send you some emails and we can chat about it. So let me stop there and turn it back to the rest of the group. Thank you.
Thanks, Richard. Josh, I'm not sure. I think that's for you and Dana in part. I know you answered the first of Richard's 3 questions, but maybe we can focus on the likelihood of getting a waiver, or if it all hinges on that. And then that last third question that Richard just asked.
Sure. Just briefly, I think that one reason that Maryland as a state moved forward, and Vermont also has a somewhat similar system, although it's based in an ACO. So Maryland's not totally unique, but it's a different story in Vermont. But I do think one reason that Maryland did this is because we've had the waiver for so long, not just because of the way it ties everyone's finances together, so that there was like a shared cliff everybody was facing, but also the way that people in Maryland think about working together and having a statewide solution and getting all the hospitals on board to do something. There's like 40 years of collaboration in Maryland to do that. So I think it's a combination. I think it's pretty unlikely that a waiver like was granted in Maryland is going to happen to other places. I don't think you need to do that though, in order to be successful in having this. In fact, Maryland, the extra benefit that Maryland got when it was fee for service and could set Medicare rates is really going away, as so much money is kind of coming out of Maryland in a way for Medicare because of the global budgets. That's where that $900 million savings comes from. So Maryland is, I think, going to show that you can do this without actually getting a financial bump from Medicare. And I think it's possible to do in other areas. But the challenge that you face, which I think is serious, was there are two questions that came up. So Mark, if I could just address them. One of them, I think from the speaker who was earlier, Sandra, as well as from Bob Ross in the chat, is, you know, one of the things that made it much easier in Maryland is that the hospitals were basically financially similar and stable going in, because we had 40 years of rate setting where the rates were set in a way that the hospitals were basically doing okay. But if you try to translate that to a big state where there's some hospitals, because of payment differentials that existed, so you can do global budgets and still have payment differentials. But if the payment differentials are so severe that the poorer hospitals feel like they're getting locked in at a place that they cannot survive, that's a major problem. And some way of right-sizing the budget for those hospitals is going to be necessary in states. In Maryland, we really didn't have to do that because rate setting itself and the decades of rate setting had kind of right-sized the budgets. But in other places where the budget and the spending may be more a function of the payer mix and what the payers pay, that is not the case. And there are places that need all kinds of extra funds and other things. So you've got to rationalize the system a little bit, I think, in other states to shift to this. I don't know of any hospital that's run out of money under global budgeting. I think that Maryland has proven itself relatively resilient to some political challenges. Unlike Great Britain, the budgets can be used for things outside the hospital. You know, oftentimes these other global budget systems, it's like basically the expectation is if you don't use it, we're taking it back. In Maryland, if you don't use it, you get to keep it and invest it in other things. So it's just a different orientation, I think, than some of those other systems. It's not to say that you couldn't have a problem. And of course, we had a pandemic. And so the system can adjust to, you know, shocks and can move money around if necessary. But the basic fundamental thing is we're really expecting you to live within this budget, and you have a lot of flexibility, much less flexibility in some other countries with their global budgets. And I think that that helps.
Thanks, Josh. Anthony, I want to go to you, and then we're going to tee up Richard Pan, then Jim Wood, and then Carmen would love to pull you into the conversation, especially how on the global budgeting piece, which I know you've sort of talked about before, and what do today's conversations reinforce or shift in your thinking? Would like to hear about that. But Anthony, if you could jump in.
Thank you, Secretary. And your question was, if you had a question for me, I was blacked out. So then that allows me to ask my own questions of the presenters, who were really excellent. Don, you were, it was a wonderfully cogent, like, encapsulation of so much of what I think many of us have been working on for so long about exactly the problems in our healthcare system, and the analysis that the market just doesn't work. And it doesn't work at the individual level, where patients do not have the ability to say no. They do not have the, they are often in a monopoly situation when they're trying to get the care that they need. And it doesn't work at the macro level, where the incentives of the providers are not, you know, what we pay for services is not related to the cost or the quality or the outcomes or equity, but to, the game of who can avoid sick people, who can attract the most high margin procedures, who toward consolidation, toward other aspects, and then how do you just create a whole other incentive? And I've been struck at how we get away from the game of hot potato in our healthcare system toward something, but it does require that everybody is in, and not just all the people are in, but also all the providers are in, as was stated by our presenters. It doesn't, if there are provider, if you're holding the hospitals accountable for the health of a community, then all the hospitals need to be in, or there's issues of shifting and of game playing going on. So I'm curious to Dana, your presentation with regard to the fact that it was voluntary, and what would you think the results have been if it was not voluntary, how it would change the results and behaviors. I also was curious about how, with regard to a cost, I know at the same time there was a cost commission that was both being debated and then set up. One of the things that Don mentioned and that we're discussing here in California, if you could talk more about the relationship between what was going on system-wide with the cost commission and with the efforts at Blue Cross Blue Shield. And then I think to both, I think Josh, you already mentioned this, but not just but if you could go more into just what you think the challenges would be of trying to scale this up, not just in terms of size, but also in terms of complexity in the California market, where we just have so many different types of providers situated in very different circumstances. And would that lead toward a more regional approach or some other way to address this? So those are a few questions for our presenters. Thank you.
You want us to jump in or?
Yeah, Dana, sorry, Dana, thanks. Maybe you can start for us, Dana.
Sure. Okay. So yeah, thanks for those great questions, Anthony. I would say on the voluntary issue that, we saw a very sizable share of our provider network opting in, even in the very first year, within 4 years. So we launched our first 5-year contracts in 2009. And we did so with, now my memory's a little fuzzy, but I think it was about 25% of providers in our network. And we had aimed to get 10. We thought this was a pilot and we were aiming to get about 10. 25% in that first year. And by year 4, we had over 85% of providers in the network. Now, what happened between 2009 and 2013, of course, was that we started to see signals from the federal government that Medicare was going to go in this direction. And so I think that part of what happened in terms of our very rapid uptake in those, hold on, I'm going to go off camera because I'm getting a message that my signal is unstable. Can you hear me?
Yes.
Okay, because you all are frozen on my screen. Okay, so I think that the signal from the federal government really led to many more providers coming into the contract sooner than they otherwise might have, because they saw that providers who had come in the first year and then in the first and second years were doing well. And that here was a payer who was actually also, we didn't talk about this during the presentation, but also working to support the success of providers who came into the model. So we had created something that was within my department called the AQC support team. And that was really to help providers who volunteered to come into the model, be sure they could be successful, especially on the cost component. We had a lot of confidence that they would know how to be successful on the quality side. But on the cost side, many of them had not been in anything like a global budget contract ever, or if they had been in the 1990s, the leadership that was part of that was long gone. So I think the combination of signals coming from the federal government that this is going to be how Medicare is going to start to pay, together with knowledge that providers who came into the contract were succeeding and being helped by Blue Cross, led more providers to be willing to come into the model sooner than they otherwise might have. We also were, even though it was voluntary, we kind of were starving our fee-for-service contracts. So there was nothing that said you couldn't stay in fee-for-service and be a part of our network, but it wasn't going to be, as financially appealing as coming into the contract in terms of the potential gains. And then I'm trying to remember, Anthony, there was another part
about
of
the
your-
cost
the
relationship with the
commission,
cost commission.
Yeah, so cost commission got stood up in 2014. So, I don't really think that played a role in kind of the rapid uptake. By the time the cost commission was in place, we really did have close to our full network contracted in this way. And we already had, much of the evidence that I shared with you about the really robust way that the contract, compared to the counterfactual of not being in the contract, was reducing the rate of cost growth. However, what I will say is I think the cost commission has had an important impact on slowing the overall rate of growth in healthcare spending in Massachusetts. If you look at Massachusetts data versus US data, you can definitely see that in 2014, we start to see Massachusetts have rates of spending growth that are coming more in line with the national average, and then even below the national average, where we, as you probably know, hadn't had that. We'd been number one in overall spending on healthcare for a long time. We no longer are number one. I think we're 3 or 4, falling down the list with pride. So I think the cost commission has played a really important role. The last thing I'll say, I don't want to go on too long, is I can tell you that both part of what was brilliant about the cost commission was, for those that aren't that familiar with what they did, they created a regulation that neither payers nor providers could have spending growth higher than the equivalent of state GDP. And if you did, what was the penalty? It was being called on the carpet in front of the cost commission, which may not sound like that big of a penalty, but in the environment in Massachusetts at the time, where there was tremendous outcry about costs, about high prices of our providers, it was a very big penalty to be called on that carpet. And I know it was a motivator in our conversations with providers, when we had our contract discussions, that they were literally doing calculations about, if they got this rate increase versus another rate increase from Blue Cross Mass, how would that affect their ability to stay within the constraints of the state GDP? So absolutely think that was a very powerful move on their part. It's effectively like creating a global budget for the state. So really commend that idea to all of you. So thanks for the questions, Anthony.
Thanks, Dana. Anthony, I know you had a lot of good points, and I think the other speakers maybe can take them later. I want to go to just watching the clock. We have about an hour left for our commission conversation before we go to public comment. So be mindful of that as you make your own comments. Richard Pan, then Jim Wood, then I'm going to go to Carmen, and then Don will come back to you.
Thank you, Dr. Gali, and I really appreciate the presentations from all three speakers, Don, Dana, and Josh. And it's good to see you again, Joshua. So I had an opportunity to go down to Maryland and meet with some of the folks to talk about about the global budgeting system in Maryland hospitals, and that was very informative. I really do, I think one of the important points that comes up, it came up over and over again, is this, you have to start off with right sizing, right? And so because you can't create whether it's a global budget or whatever, if it's too small, it's a problem. If it's too big, it's a problem, right? So we have to figure out how to get to the right sizing. I do appreciate what Dr. Scheffler said about the UK. That's promised they go too small and then they try to throw in some money later to try, and that becomes a big planning problem for anybody, right? Whether you're a hospital, physician, other provider. And I would make note that right now, I think the nurses about to vote for a nationwide strike in the UK right now. So they're casting ballots to see, because the National Health Service is unwilling to give them an increase, pay increase that to meet their needs. So that's something going on right now in the UK. I really appreciate what Don talked about, this whole, I guess, interface between healthcare and social spending, because not only do I chair the health committee, I used to chair and still sit on the budget subcommittee of health and human services. So like Dr. Ghali, I actually look at the whole thing, the social service side with the health side, right? How much we spend on the Medi-Cal side, how much we spend on the social service side, what's the political will for doing, both, each one, and what can we do? And I would make note that, that it's at least in our society, even in a progressive state like California, trying to increase social service spending is really challenging. It's unfortunately, and while I think we've made some progress, certainly in the last several years, I think is a huge challenge. I would also, though, make note on the health side, aside from Medi-Cal, which is the coverage side, and I know we talked a lot about prevention and primary care, we still can't get our public health spending up. We made cuts back in the Great Recession. We made a little bit, but we're still struggling to try to get our public health spending, which is, by the way, entirely unified financing government. All right. So again, where's the political will to get the components that we actually already have under unified financing up to the level they need to be? I do find it, so I mean, I think that's going to be an important issue when it comes to right sizing. Do we have the political will to truly right size? And that's something I think we need to think about. The other, I appreciate Josh's story about the school nurses, because after all, I'm a pediatrician, I actually do school health. And I would make note in that story, you took one system, which has a unified financing, public school system, and they decided to lay off all the nurses, and it took a private entity, a hospital, to go pick them up. Okay, keep that in mind. Government, unified finance system said, nope, dumping them. Private entity, under global budget, said, we have an incentive, we're gonna pick up the cost. So again, where's the political will? What are going to be the drivers for how people make different decisions? Thank God that private entity, that hospital, decided to pick it up. If they didn't, I'm not sure what would have happened. So, so again, something to keep in mind in terms of who makes decisions and what drives those particular decisions. I think, again, back to the right sizing. I do think that, we have, as we think about our Medi-Cal system, and I appreciate the question Bob Ross put on the chat. Also, I appreciate Dr. Hernandez's response, but I'm not sure that was really an answer. So, we're still struggling. So I talked about the public health and how much we spend on public health. Well, how much are we spending on our Medi-Cal program, right? We're nowhere close. So we made some progress. Believe me, in my time in the legislature, it's a tough battle to get Medi-Cal rates up. It's really, really hard, okay? It's also really, really hard to get the social service spending up. So even when we have a lot of money. So, that's still a challenge. I do have some questions here, and I really, again, appreciate the presentations, and maybe this is primarily more for Dana and for Josh. So how I see is that, when we think about what we have to spend our money on, and maybe even Don can comment on this, and then where it goes. So I would say is that you can, so basically you can think about our population. There's different ways to cut it, but let's talk about risk, three buckets, okay? All right, you have the generally healthy population who is, you have to pay for their car accidents, other injuries and stuff, but they're acute, right? All right, you have that group. You have people with chronic conditions that are fairly common, like diabetes, asthma, or so forth. So you have a lot of measures for those, right? And I think that goes to what Dana was talking about in terms of number of measures. And then you have people who have, chronic, rare diseases, chronic rare diseases that can be costly too. Oftentimes, genetic, other types of conditions. By the way, those are probably some of the diseases that tend to have higher cost pharmaceuticals and so forth. But they're also, because of the rarity of them, and as a pediatrician, like a lot of pediatric conditions fall under this, they don't have really good quality measures per se. I'm not saying there aren't quality measures, but because the numbers, it's hard to measure, right? Because in terms of number of patients you're going to take care of, unless you're a subspecialist in that particular area, is going to be fairly small as a proportion of everyone else. So when we think about trying to do value-based purchasing, which I'm all a big fan of, our payment systems, one could argue that, for example, for prevention, does it make sense to capitate prevention, right? Shouldn't you just say, because if everyone's supposed to get, the shots, everyone's supposed to get their weights done every year, et cetera, should we just pay people for when it's done, as long as it's done on the appropriate frequency, not overly too much? Then you have the chronic conditions with the measures. So those are easier on the value, in terms of like, here's the outcomes and so forth. And then, but what do we do about the rare disease part? That's about, I think about, people have estimated around 400 billion or so nationally, a little over $400 billion of direct healthcare spending. Do the California 10%, that's about 40 billion. How we do that? Or we just lump them in with everyone else with chronic disease and says, well, we'll let the people with diabetes and asthma and so forth drive what we do for everybody, even for the people who don't really fit in that box, but maybe we'll try to squeeze them in there. So can we so it comes to payment, and suppose you're a specialist that takes care of a rare, you're a pediatric rheumatologist. How does that work out for you, or the primary care doctor of a patient who has one of these diseases that requires a primary pediatric rheumatologist? How does that work for you in terms of trying to work your budget? So so maybe I'll start off with Dana. I don't know how you handle that in Massachusetts, or that just kind of lumped in. So I don't know how granular you got in some of this stuff in terms of trying to do global budgeting and creating incentives for actually improving care for chronic conditions.
Yeah, thanks, Richard. So I'll be very brief. So what I'll say is in our contract, everything was in. So those rare conditions were in. And we did not have good measures for them, or any measures. In my role as one of the MedPAC commissioners, we're giving a lot of thought right now to the role of bundles. I can say that when I was at Blue Cross Mass, we were not involved in doing bundle payment at all. We considered it. We had some providers who, before coming to the AQC, wanted to do bundles instead. For me personally, the idea of negotiating one condition or body part at a time gave me an incredible headache, knowing just what it was like negotiating a global budget, not to mention, all the concerns about, fragmenting care and so forth. So we did not work with bundles, but I am involved in some thinking right now as part of MedPAC's work on how we can define a parsimonious set of bundled payments that could be valuable as complements to a global budget construct. And you bring up an interesting criterion, which is, could bundles be valuable for rare conditions? Just finally, to on more common chronic conditions, yes, those were very much a part of what our model was focused on, as I think you probably saw in the measure set and in the comments that I made. So thanks.
How to do the hospitals, Josh?
So thanks for that question. I would say that it's really important to realize our healthcare system needs to be providing the best care to people who are incredibly sick and pushing the envelope of discoveries too. Hospitals like Johns Hopkins are so deeply invested in figuring out the next generation of treatments that, any step back from that would be a real loss. So you can't, I think of it as the best way to think it is that we want the healthcare system to both have the idea of providing appropriate, cutting edge, high-tech care and for those who need it, and be a community hospital, to deliver good community health results for the population. And there are a lot of things that really don't fall into either of those categories. That's what you want to get rid of, like preventable admissions for, conditions where you could really help people, not get sick and come back again and again for heart failure. You got to really focus on those things, but you're not trying to skimp on care for people who really need it. In fact, you're trying to free up resources to put more into care like that. If to use a pediatric example, I think one of my medical school roommates wrote a paper that showed just how much money we spend for neonatal, neonates who are low birth weight while they're in the hospital. And then they leave the hospital and they get hardly anything. And it makes them likely to bounce back and not thrive. We don't invest in the systems that help them after they leave, after spending millions of dollars for them to get through like 3-6 months of the first 3 or 6 months of life. You put a global budget on, you really have the incentive to invest in those things that overall help the kids and not just, wait for them to have lung problems and come right back to the hospital. But at the same time, you have to be able to prioritize, the latest type of investigation. It's interesting though, when you have a global budget, people really look to see whether it matters for the patient. It's not so much what you can bill. Like fee for service drives innovation in a direction that doesn't always produce better health. You want to have a driver for innovation that is oriented towards actually improving health and helping the patients.
I appreciate that. I mean, I think part of the challenge is the lack of measures for that set. So therefore you're rewarded for some, but maybe not for the others. And also we know that the sickest 5% spends, about, basically about half of our healthcare. I don't know, Don, did you have any, I know you're going to ask some other comments later, but.
No, I'll jump in as well. I will say this, that I think, and I think this is mostly agreement with Josh, but we do in the US, one of the things we do really well is we treat people with very rare, very complex medical conditions. So when I was at the Commonwealth Fund, we ran a fellowship for a year called the Harkness Fellowship, and we brought over sort of a mix of physician researchers, health economists, and health system researchers. And at the end of the year, every year, the person who directed that program would ask the same question, which is, having been in the United States for a year, usually with your family, having been now through 2 different health systems, would you be treated, would you prefer your own system? Would you prefer to be treated in the US for you and your family? And almost all of them consistently would say, we prefer our home system. Many of them would qualify that and say, but if I had a really rare disease, a rare form of cancer, this is, I would consider the US system, or even stronger, this is where I would want to be treated. So you have a problem of scale in developing quality measures. Dana, can go into detail about that, obviously. But I don't think it's a problem in the same way it's a problem with things that happen much more commonly. And for us anyway, it's not they're expensive one-offs. They are not what are driving our costs. What are driving our costs are chronic conditions and things that are preventable, much more common. So that's the lens. The exception is on the pharma side. And some of the drugs that we use to treat some of these rare conditions are tremendous, but they're also incredibly expensive. So I think the answer is partially, it's going to differ when you look at the pharma side and when you look at the actual treatment side.
Thanks, Don. I want to keep us moving because I'm just sensitive to the clock. Jim Wood, I want you to jump in. And then we'll go to Carmen, and then Don, you had your hand up separately. I'm not sure if it's still up, but we'll come to you right afterwards. So Jim, go ahead.
Great. Well, thank you. These were fabulous presentations, and being somewhat of a data nerd and a policy geek, this is like the best way to start a Monday, quite frankly. And so thank you all for your perspectives and the work you've done on this. I have a couple pointed questions. One is, the first one is, do any of you think that California should go in the direction of a fee-for-service model as part of a unified publicly financed provider model?
Who wants to jump in first? Josh, maybe I'll start with you and then go Dana and Don.
Sorry, I do not think that. I don't think fee-for-service is really aligned for health, you know? And so my focus from public health perspective is we want to have people and communities healthier, and I just don't think fee-for-service is really compatible with that. And even if it's a single payer fee-for-service, I don't think it's really well aligned with health.
Yeah, I agree with that. You know, I think you've heard a lot of the value today of paying in ways that create accountability for cost, quality, and health. And I think that the cost implications are well laid out, but Josh's point is one that you know, I think would really be important to focus on. Is we know we get what we pay for. When you pay by the piece, you get lots of pieces, and they aren't necessarily pointing in the direction that you really want to go, which is improving the health of the population, and presumably improving health equity in the population as well. The fact that you can do that while also helping to control cost and cost growth, you know, to me makes it really compelling that you move away from fee-for-service to some kind of budgeted models.
And I agree with Josh and Dana.
Thank you. So first of all, I also want to say I very much appreciate the perspective of Dana, I believe, was talking about investing more in poorer communities led to better outcomes overall. As we seek to improve equity, some of the communities I represent tend to be some of the poorest in the states, with highest rates of opioid addiction and highest rates of adverse childhood experiences. And so investing in those communities to help bring them up, I think, is good for the entire system in the long run. Also, heard someone reference health information data systems, something very important to me. I think that was you, Josh, talking about that, and how hospitals can all coordinate so that everybody knows what somebody has had, so that we're not duplicating services. We're making sure that the quality of care or the appropriateness of care happens as well. I'm curious, some of the numbers, and you may not have this today, but I am curious, some of the numbers around the global budgeting, around the AQC contracts, the numbers they're a little dated, and I know it takes time to compile this information. So I think the AQC contracts were like 2009 to 2014. We're in 2021 now. So I'm curious as to how these are playing out long term. And if it's somewhere that I missed it, I apologize. I'll go back and look at my materials again. One question for Don, and then a question for all of you, really, that I hope will be quick, or maybe not be quick. So Don, we have we said 1.5 million people are part of the CalPERS program. How many of those are retirees, percentage?
So, a little less than half.
Less than half. Okay. And as we transition, as we as a state were to transition to some other system, will we have, are all those benefits bargained? Or is that going to be, how does that happen?
So that is not a short conversation. I will say that, you know, those are we have a contractual, the employers who offer those benefits to their employees have contracts with them. There's a lot of case law about whether, even if you can tinker with them. But you know, not an easy answer there. I will leave it at that.
Okay, that's fine. And the question I have for Josh and Dana here is, okay, we have the AQCs, we have the cost commission in Massachusetts, we have global payments for hospitals in Maryland. If you could wave a magic wand now that we're a few years out, what would you do to enhance the effectiveness of those? What's missing?
Yeah, I'll go first, Jim, but very interested, Josh, in your perspective on this. I kind of had this question for you myself. But what I would say, first of all, just to be clear, Jim, the AQC goes on, right? So yes, it was launched in 2009. The last study, the 8-year study, was through 2016. One of the important things that happened, I believe is 2014, but I'm not 100% sure, was that we brought the PPO population into those contracts as well. So the contracts had started out with our HMO populations. And, you know, lots of skeptics over the years of the Harvard Medical School studies were saying, sure, you can do this in HMO. Most of the country's PPO. You can't do it in PPO, but we did. And actually Medicare has as well, right, with its ACO program. So, and it goes on. And I think if I could wave a magic wand, I actually would put the three together. I would definitely have a cost commission like the Massachusetts Cost Commission that holds providers and payers accountable to cost growth no greater than the state GDP. I think that's powerful. You decide what the consequences are for those who miss that mark. I would absolutely have global budget contracts like the AQC for provider systems, but I'm very interested in the idea of complementing that with hospital-based payment reform. Because I left Blue Cross at the end of 2018 to go to Haven. And one of the things that I was working on at that time was a payment model for hospitals that would create accountability for a hospital to reduce and manage total cost of care in its catchment area, so that hospitals would be motivated to support the success of the provider practices in its market at managing their AQC budgets. But so when even if it wasn't their affiliated provider practice, when patients from that practice would show up at the hospital, I wanted the hospital to have the incentive to think really hard before they admit that patient to a bed coming through the ED, or even treating the patient as an ED patient instead of as an urgent care patient. And so I really was coming to a point of view that we were going to stall out in how much farther we could go successfully, especially with all the consolidation and with such hospital driven systems prevailing in our network, without doing something to reform hospitals' fee-for-service incentives from DRGs. So I think the coupling of these two types of budgeted models together with a cost commission would be very powerful.
Wow, I think that would be very exciting to see. I would just say, for me, to your question, you see in your areas the enormous health needs that are there. In the meantime, we have a healthcare system that we spend an enormous amount of money for. I think fundamentally, this is about saying to the healthcare system, we need more health produced for the amount of money that we're giving. It's a different kind of value than maybe a traditional metric of value, which might be just looking within the healthcare system. But we want to see some of these really serious challenges get better in different places, and these disparities reduced, and more people have opportunity. And we need you to be aligned with that. And there are things that you can do, and we want to pay you for that. I think that's the big picture. And you can pay people for that and they can still not totally get it. So I guess I would say I would just love for people's, in healthcare to see the value of that, not to say that we shouldn't be providing amazing care to people with serious and rare conditions, but that there's a real alignment between we are trying to make our community healthier. We want people to be walking around the community healthier. That's a core goal. And when you start to do that, it opens up all kinds of things that healthcare can do. There was a comment like, well, the healthcare system shouldn't be, penalized if there isn't a smoking ban. But on the other hand, I'm not saying penalize them. Don't we want the healthcare system as a full partner in getting policies that make a community healthier? And figuring out ways to, support policy change that maybe they're not even in the middle of. But you can start to see the potential. I just think if we try to solve some of the problems that we have for health without really having high expectations for the healthcare system, we're leaving a lot on the side because of just how powerful and expensive, frankly, healthcare is. And I'm just going to put into the chat a project I'm working on where we talk about what it could be like for a healthcare system, a hospital, to really be thinking about the health of its community and equity, as a core measure, what that could actually look like. And you get to see the kinds of things that are within the reach of healthcare systems to do. And I think we could see a lot more of that if they embrace this idea that their mission is really to improve community health, or a big part of their mission.
Thank you. One final question, if it's okay. If not, I'll pass. Mark?
Jim, if we could maybe come back to it, if that's all right.
That's fine. That's fine.
Thanks a lot.
Secretary Gall, you've cut out. I do think Commissioner Comsty, you were next, so over to you.
Yeah, I'll assume what Secretary Galley was going to ask me about, because I have worked a lot on developing within existing single payer proposals payment structures that incorporate ideas of global budgeting and other types of proposals. And I wanted to kind of start my comments to kind of do some level setting here, which is that, when we're talking about single payer, we aren't, it's false to equate single payer with fee for service, right? So, in our single payer proposals that we have this combination of things. And I think, we had to get away from that kind of that attempt to stratify the payment structures. And I think, one of the things that I want to bring us back to is the idea that, what's driving the increased costs again, which is what Don showed, which is it's prices and it's, there's administrative costs. So let's try to fix those types of things. Also, when we're thinking about other types of, social determinants of health. And I think, going back to Don's original kind of frameworking, I do think, there is, as he was indicating, there is a philosophical underpinning to this discussion, which is, which is why I always try to think of it like, what are the incentives that we're giving towards providers, and why I am very, very concerned about risk-based payments, because, they create a very, very serious medical ethical issue where we're trying to, one of the things we've identified in the problems with our system is that, potentially providers have economic motivations, and, I want to try to minimize the economic interests of doctors and providers. And I think risk-based payments flips that to make sure the doctors think about how much each individual patient, depending on their population or their diagnosis group, how that will impact their pocketbook. So I think we have to be very careful when we start talking about market incentives and to drive, change in social determinants of health, to drive changes in behavior of doctors. And I think, this drive, we know it's created inequity in our healthcare infrastructure, that both literally and economically, our distribution of healthcare resources has been stratified because of the economic incentive. That's how we get healthcare deserts. That's how we get hospitals closing L&Ds. That's how we get hospitals not investing in seismic retrofitting here in California. So, you know, I think we have to be really careful when we're talking about payment incentives to meet quality outcomes and to address inequities, because, you know, payments are different than public investment. And I think we need to be very careful when we're talking about it, because public investment and directed targeted programs, public programs to invest in healthcare are very different than economic incentives through payments. And I think, you know, that's the real big distinction that I really want us to think about. You know, and we also know that when we're focusing on risk-based payments, we're focusing on metrics-based payments and data-driven payments, we're actually increasing the administrative burden on healthcare providers. You know, any doctor or nurse will know the ridiculous nature of coding and how much time and energy and actual costs that creates for our system because of the heavy metrics. And, you know, and I think that also relates to, you know, hyper consolidation in the healthcare system. The FTC is looking at that right now. You know, another thing that I want to, you know, I flagged this multiple times in our past meetings, but, you know, risk adjustments, particularly socially based risk adjustments, we have to be incredibly careful about, because when we're talking about creating metrics based on social determinants of health, social concepts, social markers, that means we have to build metrics on social stereotypes. And when that happens, particularly when it comes to race and ethnicity, we can embed racial and ethnic stereotypes in our system. We know it happens today. We know it's happened. You know, there's a big study by Obermeyer in 2019 about the healthcare algorithm that built in and used race as a proxy for cost, and it resulted in African Americans receiving less care than their similarly sick white counterparts. That's a problem, and we have to be careful about it. You know, and it happens a lot, race correction within the algorithms of our metrics. So I really want us to consider that. And I think, you know, I flagged this in my comments to the consultants' analytic findings, but I think it's interesting. And you know, what do hospitals and providers actually use their increased payments for, their risk adjustment payments for? And you know, Rick Kroenig actually has a great article that was released this year about what providers and plans use their increased coding, intensity coding for. And they primarily use it for Medicare Advantage plans in Rick's study. Medicare Advantage plans put that increased risk adjustment payment towards medical loss ratio rather than care, rather than giving it back to the patients. So, you know, this all comes back to, you know, when we're thinking about, you know, this is why in the single payer proposals, we use global budgeting as a mechanism to incentivize transparency in the process, so we know where the healthcare money is going towards. And I think that's why global budgeting is really, really important, because when we're in a unified system and we have a single negotiator with the hospitals, with the providers, we can actually look at the receipts, the literal receipts of the hospitals to see, what are you paying for? Are you paying for excess marketing costs? Are you paying for excess compensation for your administrators, or are you actually investing it in care? And are you investing it in prevention? Are you investing it in primary care? And I think that's the really, really important part, which I think Josh was talking about, which is that you can see where the money is going. And you know, I think it is a really fundamental shift on how we look at hospital payments. And I think, you know, in our single payer proposal, that we could potentially move that towards towards clinics as well and outside the hospital model. And then, I want to, just quickly touch upon how it's a little bit different. Our global budgeting that we've created in single payer proposals is different than say the Blue Cross Blue Shield model in Massachusetts, where it isn't, it isn't based on risk and hospital risk and reducing costs because of the risks of the hospital. It's fundamentally built on paying the hospitals what they need to pay for their patients. And I think we talked about this earlier. So the global budgeting in the single payer proposals, there'd be a combination of factors. So it'd be historical factors, adjustments based on predicted increases of need, and then also, making sure that workers are paid fairly, making sure that hospitals actually prepare for pandemics and they have a stockpile of PPE. We can build these types of things within the budget so that the system can say, are you prepared, hospital? Are you prepared, facility, to address all these different things that we as this, the residents of California care about? And I think one of the key parts of the global budgeting proposals is also that we have built in areas where increases in payments to upfront can be used to mitigate availability and accessibility problems in availability and accessibility of healthcare provision. So, if a hospital needs more money to pay for more staff, more full-time employees to staff so that they have safe staffing levels, we can pay the hospital that money. We can pay the hospital to keep to extend their hours if we've identified a problem of people not being able to schedule visits within normal operating hours. We could pay the hospital to renovate a wing of their facilities. So I think that's really the beauty of global budgeting, is that we can target where the money goes towards, and also meeting the needs of different patient populations. And I think the one other thing that I really think is important when we're talking about the single payer proposals that are out there. So, there's global budgeting for institutional providers, and then for individual providers, there's a proposal. The proposal that we have out there would give an option for salaries for providers. Would they, so that individual providers, if you're an individual doctor, you can opt to get a salary instead of fee for service. So I think that in and of itself is a very concept that I think I want to hear more about what other folks think about that, because it takes away, the problematic potential for fee for service, right? But we also have a system where we can monitor individual providers for potential abuse under a fee for service system, or they can go towards a salary option where where a provider's behavior aren't necessarily tied to the volume of services. So I think those are kind of the creative ways that we're trying to address all these problems in single payer proposals. Higher transparency, better monitoring by a single system, and then we can do some real serious health planning over an entire entire state, an entire country, and we can target, and we being the public, the public sector, and the government can target monies towards programs specifically, rather than letting the market tease it out, because it hasn't been working. Market competition hasn't been working, and we don't want to incentivize bad behaviors by private entities, and we don't want to shift all of the burdens of the health system onto the private sector. I think it's really important that we keep our public officials accountable for funding both social programs and public health programs. And I think, I think it is a big shift, and I do think that
healthcare corporations will be resistant, but I think that's why it's important to do it in a unified way, because when you get all the patients, all the providers will want to come to our system. And I think that, to fundamentally address Anthony's original question, which is how do you get all the providers to come in? You get all the patients. There's a lot in there, but I'll stop for now.
All right, Carmen, thanks. I just, there was a lot there. I do want to pick up just early part of your comment to Dana and Josh, just ask you to quickly answer it. And then I'm going to try to do as normal. As usual, we get some last hands up towards the end. I want to make sure we give them a chance to ask their questions. Dana and Josh, both in Massachusetts and Maryland, what did your sort of alternative payment approaches do to administrative burden? What did you see in terms of any transformations there? And the sort of provider perspective on participating in one, the before and after, if you will.
Briefly, I'll say that we had looked to have more impact on administrative burden than the AQC model did. Specifically, we really thought that with this model, providers would want us to turn off things like utilization management. And we found quite the reverse, that they came to want us to continue it because they saw it as something that would support their success in the model. So we did work over those years on achieving administrative efficiencies, but those had less to do with our AQC model and more to do with some multi-payer work that we were engaged in to try to accomplish efficiencies of scale and in things like licensing and some other aspects.
Yeah,
Thanks,
I would
Dana.
say that,
Josh, quick, yeah.
just real quick, there's a lot of efficiency to go to a multi-payer, going from just complete anarchy fee for service to a multi-payer system where there's a rate card. So we had already, made that step in Maryland. When we went to global budgets, it added a little bit of complexity for our hospitals about how to succeed under global budgets. So I don't necessarily think it was, the hospitals still have to deal with multiple payers. So there's still a fair amount of administrative expenses that go with that. But where the efficiency is in a multi-payer environment like Maryland is on the clinical transformation side. Like if a hospital is going to change a service, it works for everyone. It's not just in one payer, you're making money, but the other payer, you're losing money. If you try to do something different, it really allows the hospitals to say, what are we going to do better by this group of patients or that group of patients, and then really implement it across everybody. I think that's an efficiency. It's a little different than administrative efficiency, though.
Mark, can I just add on to this? Because
please, yeah, jump in.
Yeah, we do an interesting thing on administrative fees. So we actually negotiate them as part of the contract, and most of our contracts are what's called flex funded. So if the plan in any given year makes more than the pre-agreed upon administrative fees that are part of the contract, they get returned back to CalPERS.
Got it. Yeah, John, that's helpful to hear, and something we probably want to learn about more soon. Carmen, like I said, there was a lot there. Appreciate the full comment, and I know we'll have a chance to come back to some of it soon. I see a couple of new hands up. Want to give commissioners last chance to throw their new hand up or hand of someone who hasn't already commented before I circle back to Richard Scheffler and Jim Wood, who I know had an additional question. So we'll start with Jenny and then go to Bill. Go ahead, Jenny.
Yes, well, thank you. Again, just affirming the triad of presentations have been great, as well as the questions. So I'm picking up on, if you don't mind, the thinking of making it happen. One is the big gnarly policy side, but making things happen. I saw a comment that Josh, you had about starting regionally, rather than kind of day number one, everything turns on. One of my questions, and some of you know that I come from 25 years of PACE capitation approach, is the idea of doing this not just by regions, or if not by regions, by population. And because when Dawn mentioned that, you know, the contracts that you have with Medicare are pretty complex to unpack to try to make that blend into everything else. Is there any wisdom in thinking about a population-based approach, say, starting off with payment systems that are still needing to change, but perhaps the majority of Medi-Cal is really about families and children. And I just wonder whether there's a structural simplicity of looking at some of the system changes we're thinking about, but doing it on populations that are not ERISA directly, and but it could be perhaps Medi-Cal with women and children, or even crippled children's services for complexity. So just a question about execution. I'd appreciate all of your respective reactions to that.
Just jump in. I think that's a very wise question. And, you know, particularly because there is, in many places, I don't know it in every place, a pretty different pediatric care system. You could imagine that pediatrics goes first for different things, or at least, you know, at least shows that it could be done. It's just that pediatrics are just so small relative to everything else that you might not get that much, and the rest of the healthcare system might be like, well, I mean, you haven't really shown much if you can just show pediatrics. So now I do think that there are places in the country, to your other question about doing it by payer, that have thought about trying to phase in global budgets within a region by payer, starting with the public payers. And that's certainly an approach, particularly if in a region, the public payers are an enormous percentage of the patients, which can be the case. So if you have, you know, basically you want to start, I think, with the highest percentage of patients that you can start with realistically. And so if, you know, you've got a location where you've got 80% in Medicaid and Medicare, you know, you can start there and then build that. You've got a pretty strong base. Similarly, if you're starting with like 90% of the kids in a pediatric system, you could start there. I think those are ways, if you want to go even slower and sort of, or get things going faster. It's another way to think about it. Not really going even slower, but getting things going faster. You could try that. But I think the goal you're going for is really as many people in as possible to get that clinical transformation underneath, and to align the healthcare system fundamentally with the health of the community that it serves.
Thanks, Josh.
Yeah, I'll offer a perspective that you know might sound counter, but it's probably not. In our experience, you know, as I shared in the story, we were starting ahead of other payers, including public payers. And what we found was that, in fact, as I mentioned, a very large share of our network was willing to come in even at the very beginning, right? Even in our first year. And I think that was because we were striking the sweet spot of having enough of their membership. So we represent, you know, as a Blues plan, in the commercial book of business, we were probably 60% of their commercial book, and then probably something like 35 or 40% of their total book. So it was enough to make it worthwhile, and not so much that it was frightening to them in terms of, you know, betting the farm on this model that they had no experience with. And so, you know, so much has changed, at least in the public discourse, about the importance of, you know, multi-payer, you know, as much as you can. So I don't know the right answer. I imagine it could be the case that the provider systems in a market really don't want to do this if it's not going to be close to all in. But I could also imagine that there are some who still feel like, let me test the waters with something that is a big enough share to make it worth my while, particularly if, as I described before, there's going to be some support going with it to help you be successful. And then once I figure out how to do this, let's bring in the rest. So I think you have to start test the waters and see what, providers in different areas of California would be up for.
Thanks, Dana and Josh. Bill, do you want to jump in?
Yes, I want to compliment Don and Dana and Josh for really outstanding presentations. This is a wonderful meeting today. Thank you. I want to make one quick observation, but I'm not and one quick question. My observation is that both Josh and Dana is talking about contracting or organization, like hospital is often mentioned, or a network. And how does that hospital or network actually then motivate the practitioners to deliver the right outcome? It's a black box. And I know we don't have time to get your answers. I would really be grateful if you can give me some material to read on that. I think that's a black, that's something we'd like to know more. My question to Dana and Josh is this. You are contracting to a hospital or a network. How do the hospital really coordinate or integrate with the primary care doctors? Do you look at that specifically? Because we are emphasizing the importance of primary care and prevention. How do you assure your contracting and payment is to get that established between hospital and primary care practitioners? Thank you.
I'll respond just, and I know we're almost at the 2:30 East Coast time. Was that make it 11:30 your time? And we're due to conclude. I'm due to sign off. But just very briefly, our contract, Dr. Shah, was really a primary care centric model, even though it wasn't with primary care practices exclusively. It was with providers regardless of their structure, and in many cases that meant multi-hospital systems. But the orientation was toward a population defined based on their primary care relationships. And in some cases, especially in the early years, before some of the market changes unfolded, we did have groups that were in the model that were physician practices without hospitals. And that created some very powerful market effects in terms of provider systems that were moving business from, Harvard Medical School affiliated hospitals where they've had a 25-year relationship to a different Harvard Medical School affiliated hospital that happens to have much lower prices and is only a mile, less than a mile away. They could see each other out their windows. Moving business from an academic children's teaching hospital to a different academic children's teaching hospital. So there were some very powerful effects of the combination of cost and quality incentives that the primary care and specialty care practices had as part of the AQC that I think are instructive. I'd be interested from the Maryland perspective how the market effects worked.
I would say those are two really great questions. For the first one, there are a variety of ways that the hospitals have responded for it in terms of how they have structured their payments to others and to their employees and affiliated practices. In general, I would say the smaller hospitals in some ways have been more nimble, and there sometimes can be a lag for the larger hospitals to kind of adjust underneath what their overall incentive is. So I think that has created a drag a little bit on the model, but that is definitely part of it. For primary care, I think, and this is sort of how Maryland came about, is that we had a crisis in hospital payment and we had to address it. And initially we wanted a primary care model. CMS gave it to us, I think, for year 5. But the idea is sort of parallel play, that we have for a population, the hospitals oriented effectively and the primary care doctors oriented in the same direction. And then we are creating, the hope and some mechanisms for them to be engaged. I'll tell you, I visited a rural hospital and I asked them, how it's going with the primary care doctors. And they said, it's great. I mean, I had no idea that they existed, So this is a system that because they realize that they'll do better if they can prevent readmissions and preventable admissions, hospitals have welcomed in the primary care. That they say, oh, we've got this new, system of working with our primary care doctors. So, but it's not because they're all under one budget. In other places, having them all under one budget, can work pretty well. In Maryland, because of the way it's developed, our goal is to have them both incentivized in the same direction and hope that they can work it out. But I think, we generally have set these broad financial incentives and then we give a lot of flexibility to the healthcare system to work it out. But primary care has very much been in mind from the beginning.
All right. Thanks, Bill. Dana, I know you've got to jump. I just want to say a tremendous thank you to you. I think, Josh, if you're able to stay to hear a little bit more, Don, I know you will. But Dana, thank you for your time today, your excellent presentation, the leadership that you showed in Massachusetts and have taken beyond. We're very grateful for your perspective and sharing some of your lessons here. Richard Scheffler. Oh, sorry, go ahead, Dana.
Oh, I was just saying, my pleasure. And anything that I personally can do to be helpful to this commission, please don't hesitate to call on me.
And we may very well. So
Bye,
appreciate what you did today. Richard Scheffler, if you can have a 30-second comment, and then I'm going to wrap us up.
I'm gonna have to talk quickly. So first I want to say that no one is suggesting, and not me, that we want to have race-based or cultural-based or language-based payments, because I think that would be a mistake and it could and might stereotype people. I think the way to deal with health disparities is at the community level. And I think there are a lot of models out there now to deal with communities rather than to stereotype various people who have health disparities. And you can get very, very similar results. More to say about that later. I want to emphasize one point that Bill raised and others. Global budgets do not, and Josh as well said it particularly well, global budgets do not tell the organization, the hospital, or the provider how to pay their doctors or nurses. It gives them a budget and it gives them the flexibility to decide how they want to reimburse the physicians, nurses, and other healthcare providers. We all know that Kaiser, which is 30% of our market, gets a global budget because it has a capitation payment, and it primarily pays its doctors on salary with a bonus. And a lot of the bonus has to do with clinically how well the doctor performs. So equalizing and saying that risk-based payments, given an incentive to doctors or monetary incentives, is just not understanding that the risk-based payments go to the organization and each doctor does not get a risk-based payment or any other health provider in the system. So I think we need to clarify that, make it absolutely clear to everybody that that's not what we're talking about. And Dana has left, but I will communicate with her. I think she had the grand design for the grant solution and payment, and that is risk-based capitation with the right incentives to produce quality and high outcomes with a cost control mechanism in Massachusetts. And had they put that combination together, which we can in California, I think we have a path forward to try to control costs and make them more accessible to the citizens of California. So I don't know if I made my 30 seconds, but I did my best. Thanks, Mark.
Well, I lent you 60 of mine, so that's okay. Thank you for helping wrap up. You summarized certainly some the issue on what global budgets do and don't do. I think was a very important point. Richard, let me just wrap up by saying a couple things. I think today's conversation was, as many of you said, wonderful and great. Appreciate the three presenters and what they left us to be thinking about. I think this idea that there is an exciting part, certainly, to the unified financing conversation about how we actually use the payments and the funding that comes into that big pot to actually deliver health, not just healthcare, that we can drive in some examples that were discussed today, but hopefully some other innovations and tweaks, learning from these lessons, that California may have some suggestions and versions of these ideas that help us drive to the unique challenges that we have in a state of 40 million people, as complicated and complex that it is. I think that there was a lot said today that we will find in our future conversations. I will just note two additional points as we move into public comment that I want to correct. One detail on a slide earlier, that it's not November 18th, but it's actually November 17th for all of those folks who are watching. Thanks, consultant team, for correcting and catching it. That will be the next meeting date, so November 17th, not the 18th. And then I know there's been a lot of conversation about the discussion of AB 1400 in the commission. I know a lot of public comments as well as commissioner comments about this. Some of you have reached out and mentioned some thoughts on it. I'll be posting soon some comments about just the role of active legislation in the commission, what we have done already, what we plan to do that's relevant to AB 1400, and hopefully stir up some more conversation about some of the details that are recommended in that legislation and others that may end up becoming part of our conversation in the future and highlighting how it's already informed what we've done to date. So with that, Josh, thank you for sticking around. Don, thank you for taking your commissioner hat off a bit and being one of our presenters. Really excellent presentations to both of you, and you've helped enrich the direction that we'll ultimately end up in as this commission. So with that, Karen, I'm going to turn it to you to facilitate public comment.
Thank you, Secretary Galley. We are now opening up the lines for public comment. The chat feature will be enabled for written public comment, as well as the email address, healthycaforall@chhs.ca.gov. We will be calling on raised hands one at a time until 11:59 a.m. When I invite you to speak, please state your full name and any affiliation you have with an organization. Please keep your comments to 1 minute. After a reminder or two, forgive me, but I will need to move on to the next speaker to allow as many voices as possible. Okay, with that, we're going to start off with inviting Hector Flores to speak.
Great, thank you very much. I'm Hector Flores. I'm a family physician in East Los Angeles. Great presentations today. What I would recommend for the commission is to look at two models that apply those principles presented today that are already here in California. One would be to invite Kaiser Permanente, and probably at a polar extreme in the opposite would be the public health hospitals. Kaiser Permanente has been around for 80 years. I'm not affiliated with them, so I have no particular bent with them, but they've been around for 80 years, and I think they were the first accountable care organization before ACO's term was coined, and certainly have performed great for the last 30 years. They have the concept of global budgeting for their hospitals, as well as global budgeting for their physicians, with the incentives built in for physician value-based performance. Obviously, they struggle with Medi-Cal and they struggle with the uninsured, being an insurance company, but there's a lot to be learned, especially because they're in 8 different states.
Thank you,
Secondly, inviting the public hospitals, the waiver, the PRIME program, which was, the redesign of the public hospitals, and now looking at global payment. How is the public system, the ultimate safety net, approaching this global budgeting strategy? And are they getting the right actuarial support to make sure that they're negotiating the right budgets? Because that'll be how they sustain long-term. Thank you.
Charles Weber, you're next.
Okay, I think there's some roadblocks to how we move forward, and some of it's political. There's obviously some very different approaches to this. Some of it's economic. There's going to be some strong economic forces against moving to a single payer system. To me, I'd like to just throw everything aside and say, how much money is coming in? What does it cost us right now to do the various aspects of our healthcare system in California today? And then add up that, and then add up what does it cost to have a new single payer healthcare system in California, taking away the administrative costs and so forth. And then subtract those out, and then you know what you got to work with. But we need some real concrete figures on where we can go. And it seems like we're avoiding a lot of just nailing down the basics that we need. Thank you.
Thank you very much. Bill Honigman, we invite you to speak.
Thank you. Can you hear me?
Yes.
Thank you. Thank you, commissioners. I'm Bill Honigman, retired Kaiser emergency physician from Orange County. My comments relate to COVID-19 as the most pertinent and pressing example of why we need to move ahead with the modeling for provider reimbursement that does exist in AB 1400, the glaring inadequacies of commercial payers to allocate direly needed health resources in the pandemic, not just for PPE, universal testing, and contact tracing that have been inadequate, but also assurance that chronic comorbidities that compound the risk to the public at large of contracting, ultimately suffering or dying from COVID-19. This shows that such market-based systems need to be cut out altogether, not bargained with through rate setting or otherwise depending on any market-based entities to allocate these resources. And more generally, this is, as Commissioner Kosky said, what creates our healthcare deserts. Thank you. Please move forward with the modeling in AB 1400.
Thank you. Marie Lopez, please go ahead.
Thank you so very much. Appreciate the time. To prioritize patient care, the system must minimize providers' profit motive and ensure that healthcare dollars go towards care. Checks on provider profit motive can be built into the system, and a single payer system can pay providers closer to cost so they are less incentivized to consider profits and care decisions. Hospitals can be paid annual negotiated budgets through a global budgeting system, and they do not need to push their doctors to diagnose patients with illnesses that get risk-adjusted bonuses or to upcode services to maximize profits for shareholders. Executive pays or marketing. Transparent direct rate negotiations between the system and providers would reduce inflated rates and minimize the distortionary effect of overpaying for some specialties and services and underpaying for others. Thank you.
Thank you. Patty Harvey, please go ahead.
Patty Harvey. I am co-chair of Healthcare for All and Physicians for a National Health Program in Humboldt County. I'm trying to put my video on, but it doesn't seem to work, so sorry about that. I have a question around the concept of provider responsibility to lower cost. Why hasn't the commission addressed a huge source of rising costs that drive out of control healthcare spending, namely the profit, overhead, administrative waste, and abuse by corporate health insurance companies to the tune of 30 cents on the dollar? For example, Medicare Advantage has been overpaid $143 billion in the past 20 years, and health insurance companies have paid out penalties of $350 billion for fraud. Why do we need these middlemen? So why couldn't the AQC structures described by Dana and the global budgeting described by Joshua be administered by a not-for-profit government agency, thereby obviating insurance profit, overhead, and waste and abuse? Incidentally, AB 1400 is a vehicle that would deliver those concepts. Thank you.
Thank you, Ms. Harvey. Tim Bailish, please go ahead.
Thank you for an exceptional program. My name is Dr. Timothy Bilash. I'm an obstetrician gynecologist based in San Diego. California has fewer nurses per 1,000 population, below the national average, and also slightly lower than the average Maryland levels. How does the nurse staffing in hospitals and outpatient settings impact total costs, the outcomes, and quality care in the settings of the global budgeting that have been proposed here?
Thank you very much. Craig Simmons, please go ahead.
Yes, Craig Simmons, I have two questions. The first is, how many commissioners would be in favor of recommending a ballot measure for implementing a payroll healthcare tax to fund a unified financing system for inclusion in the final report? The second question is, global budgeting, standardization of costs is an integral part of a single payer system. How many commissioners agree? And how do we accomplish cost standardization for inclusion in the final report? Thank you.
Thank you. Beatrice Sosa Prado, please go ahead.
Happy Indigenous Peoples Day. My name is Beatriz Sosa Prado from California Physicians Alliance, and the commissioners have engaged in numerous and important discussions about the problems in our healthcare system. And so now, focusing on solutions, I remind you that in 2019, CAPA's leaders authored the Roadmap to Golden State Care, a strategic, approachable, and realistic proposal to achieve a healthcare system that is universal, just, and equitable in California. The COVID-19 pandemic and renewed racial reckoning have brought further urgency to us writing a second version of this roadmap, which we will share with you in the next few days. To ensure that the transition to an improved healthcare system is as smooth as possible, CAPA's roadmap is carried out in 3 phases that focus on the following 5 policy categories: universality, responsible private insurance behavior, reasonable costs and prices, and 4, improved efficiencies in public systems, and lastly, improved workforce support. We look forward to working with the Commission to achieve an equitable healthcare system for all Californians. Thank you.
Thank you. Kayla Westergaard Dobson, please go ahead.
Hi, thank you. My name is Kayla Westergaard Dobson. I live in Los Angeles. My comment relates to AB 1400 system of global budgets to fund hospitals and facilities in our state. The current system we have, where insurance companies and massive healthcare corporations work to drain profit from patients, is not just immoral, it's also inefficient and a terrible use of our money. Providers deserve fair payment across the board, and patients deserve treatment that doesn't come with a side of bankruptcy. Last year, my son Arthur was born via emergency C-section at a large Los Angeles hospital, and he died 3 days later. Instead of focusing on grieving my son, I've spent the last 9 months fighting with insurance and hospital billing. My son's death has cost over $10,000 because insurance improperly billed me and the hospital overcharged me for services. The lack of transparency in our current system punishes both patients and providers, because my 10 grand didn't go to the wonderful doctors and nurses who treated my son. It now lines the pockets of overpaid executives. Global budgets, as outlined in AP 1400, ensures that healthcare dollars go to improving care and not excessive executive compensation. Please discuss AB 1400. Thank you very much.
Thank you. Ruth Carter, please go ahead.
First of all, thank you, commissioners, for your commitment to finding a path forward to quality, affordable healthcare for all. I'm the chair of the California Democratic Party Senior Caucus, and I noted that all of the presentations talked about the need for profit. It is unclear to me why there is a need to make a profit. Who is really benefiting from that profit? Additionally, it was mentioned during the first presentation, in the United States, the high cost of healthcare with terrible outcomes is particularly problematic. However, it's also interesting to note that this changes at the age of 65. Costs go down, outcomes compare favorably to other countries. What happens at the age of 65? The traditional Medicare system, which is a model that can be replicated on a larger scale and actually must have no intermediaries, as well as privatization. In the wealthiest country in the world,
thank you,
the COVID-19 pandemic has exposed the core of a healthcare system that is incapable of dealing with it. A for-profit healthcare system does not uphold the ideal of service to humankind. Thank you.
Thank you. John Scherf, you're next, please.
Yes, Don Cherf, good afternoon. I think that this commission, which seems to overwhelmingly favor a single payer healthcare system for California, has spent more than enough time debating and supporting a Medicare for all Californians that should begin the implementation already. We can't keep kicking this topic down the road. We can't just keep talking about it without any forward momentum. It's past time to stop the conversation and begin the action. Californians can wait no longer. Implement CalCare for all now. And for those concerned about financing, we have plenty of countries that have successfully implemented healthcare for all. We can easily discuss with them how they finance their systems. This is a doable action now if we would just decide to do it. Thank you.
Thank you. Jeffrey Tartagia, you're next, please.
Can you hear me?
Yes, sir.
All right, and you have a picture of me. Now, I replaced the device so I could actually have a microphone that worked, but we'll say to you is please get a better explanation of how Kaiser is doing the global planning, because as much as you've talked about it, you really haven't brought it out, just like for mental health, how you do things. Agreed that you need to find a way to do this, and you have less than 3 meetings to do this. So please come up with a better solution than what I'm hearing so far. I hear few proposals and I hear few actual occurrences that the governor can actually do. So I hope that you achieve that in these next 3 meetings of this subject. And thank you, Dr. Galway. Goodbye.
Thank you. Dennis Poske, you're next.
Thank you. I live in Petaluma. I'm a physician and a Petaluma City Council member. AB 1400 was introduced to create a single payer healthcare system that would fulfill the mission of this commission. And instead of pondering different design considerations that AB 1400 already addresses, I believe this commission should focus on studying and proposing different methods of financing the costs of single payer beyond available federal dollars. To this end, the commission should use some part of the consultant's contract to create a publicly available online calculator to explore multiple combinations of financing options for single payer in California. So again, you should discuss AB 1400 further. You should include it in your final report, and you should help California guarantee health care for all in this urgent time of need. We need single payer now. Thank you.
Thank you. Bryn O'Neill, please go ahead.
Hi, Bryn, CNA. I want everyone to remember that capitation incentivizes care denial, and quality metrics just can't fix it. Value-based payments claim to incorporate quality measures into payments to providers, but in reality, quality metric systems build in inequity through race norming and other mechanisms because they're all built on data from our systematically biased healthcare system. Over-reliance on these metrics incentivizes teaching to the test by providers who maximize reimbursements rather than provide the best care for each patient. Additionally, metrics-based incentive payments increase administrative complexities, which wastes our doctors and nurses' time and rewards large healthcare corporations who can afford to find ways to game the system. We should minimize the profit motive, maximize patient freedom of choice, add in democratic control, and create a system focused on getting equitable access to healthcare for all. So we don't need to rely so heavily on metrics to ensure quality. Thank you.
Thank you. Tim Jewett, you're next.
Good morning. Thank you for the opportunity to speak. My name is Tim Jouet. I am calling in from San Luis Obispo, Assembly District 35 this morning. Good presentation. I just want to go back to the chart. I think it was Don had in his presentation with all the discussions. If you look at that chart, if we wanted to be simple, we could close our eyes and throw a dart at that chart, and wherever it landed, we would have a better system than what we have now. So we're kind of wasting a lot of time nitpicking this, which is really fun for people that are into policy and getting wonky and discussing all those things, which leads into my other point. I don't hear a lot of talk about ease of this for the consumer and the average person who isn't interested in a meeting like this. If anyone's ever had to deal with health insurance, as one of the previous commenters did before, we need to discuss making a system that people don't have to think about. They don't think about the fire department. They don't think about the police department, things that we consider public goods. Healthcare should be the same. So we need a single payer system. And we actually have a bill in our assembly coming up AB 1400 that addresses this. Thank you.
Thank you. Ryan Skolnick, please go ahead.
Hi, everyone. Ryan Skolnick, and I want to get straight to the point. Risk adjustment incentivizes complex diagnoses, not complex care. Providers can game risk-adjusted capitation payments that the Commission seems to be so fond of by diagnosing patients with severe illnesses and then providing as little treatment as possible. And the degree of control that providers have over inputs to risk adjustment limits savings from these systems, while the mechanisms to prevent care denial are ineffective. And then in response to what Mr. Scheffler said earlier, healthcare professionals serving patients under Medicare Advantage plans have been reported being pushed by management to go back through their care notes and retroactively diagnose patients with serious conditions to increase payments from Medicare, whether or not services are actually provided to treat the condition. This increases the cost to the system and may have ramifications for the care that patients receive. Most of the extra revenue from upcoding goes to plan profits, not to care or to providers themselves. And despite so-called payment reform, the California Healthcare Foundation found that the quality of care in Medi-Cal managed care was stagnant at best between 2009 and 2018. This isn't the solution that you all think it is.
Thank you so much. Eric Vance, please go ahead.
Thank you. My name is Eric Vance. I live in the East Bay. I should note that I no longer represent any organization in a professional capacity, so I'm just commenting as a California citizen who's currently on Medi-Cal. Since January 2020, you've heard me and hundreds of others articulate pragmatic and impassioned arguments for single payer with no incrementalism nor intermediaries. The data and the demand is overwhelmingly apparent. So to further transparency, I like to focus on the inherent paradox of having perhaps the two most powerful commission members in terms of moving potential legislation such as AB 1400 forward. Ex officio members Drs. Jim Wood and Richard Pan have, as officials in the State Assembly and State Senate respectively, received a significant portion of their campaign donations from the very billion-dollar industry behemoths that stand to lose some of their current astronomical inequitable profit if single payer were to be implemented. I'll post some links. Senator Pan, you mentioned political will and drivers of making decisions. And to be frank, I see cartoon dollar signs in your eyes when you argue, and I believe bad faith, even to the point of belittling or at least dismissing all of the data and comments, in particular the report from your fellow Commissioner, Dr. Shao, who truly has the expertise and experience to address this. It seems clear to me that Commissioners Pan and Wood are serving their corporate donors at the expense of not only their constituents, but the 40 million people of the state of California and perhaps the nation by being antagonistic to California leading on single payer.
Philip Kim, you'll be our last speaker today. Please go ahead.
Hi, Philip Kim with the California Nurses Association. We should not use any type of payment model that gives a financial incentive to deny care.
Mr. Kim, I'm sorry, can you unmute one more time? Sorry, one more time. There you go.
Can you hear me? Okay,
Yes,
great.
go ahead.
So as I was saying, I just want to clarify, as Carmen mentioned, that the global budgeting included in AB 1400 is different from the Blue Cross Blue Shield or Maryland models that were presented on. In AB 1400, institutional global budgeting would fund the medical needs of our communities and pay for the true cost of care, and these funds cannot be used for profit. Global budgeting would pay hospitals and other healthcare facilities through annual operating budgets based on historical volume of services, actual expenditures, wages, projected changes, and other factors. Global budgets would ensure that our safety net hospitals that provide care to low-income, rural, and minority communities are sufficiently funded and resourced. In AB 1400, there would also be separate funding for capital expenses like building new facilities or buying equipment, and there would be a special projects budget that would address needs in medically underserved and health professional shortage areas. Each of these budget components can take healthcare disparities into account, and in the long term, a single payer system like CalCare AB 1400 will more fairly and effectively distribute care across the system. Thank you.
And with that, Secretary Galley, my apologies, we're a minute late. Back to you.
No problem, Karen. We're going to wrap up now. Thank you to our presenters. Thank you to the commissioners. Thank you to the public. More to come on this topic. Hard to do in just 3.5 hours, but we have additional chances in the future with that. I hope everyone has a good rest of their afternoon, and we will see you in November.